and clinical features, establishing his current focus is on research mainly on neglected emerging and re-emerging pathogens, including hepatitis E virus, monkeypox virus, and or other viruses. He'll be joining us virtually.
First of all, I'd like to thank the organizer for the invitation. So today my talk will focus on monkeypox virus infection. This is one of the current major global health crises. Now, we still remember smallpox, which caused many million deaths worldwide. However, because of the vaccine, this virus was eradicated. But there are many other pox viruses, for example, the monkeypox virus, but also cowpox virus. These viruses very closely relate to smallpox virus. And in the recent years, for example, from the 2022 to 2023, there was a major global outbreak of monkeypox affecting over 100 countries, and mainly caused by this called the clade 2B, one of the clades within this monkeypox virus. And currently, there's major outbreaks in Africa, mainly by called clade 1A and 1B of the monkeypox virus. There are also attention from Pakistan in response to the current monkeypox crisis, and I think your country is well prepared. And a very unique feature of this mpox disease, which we call mpox disease, the disease caused by the monkeypox virus infection. So in addition to the skin manifestation, which is common for all these pox viruses, but also systemic manifestations affect many different organs, tissues, including the brain, eye, lung, and we also studied on kidney, but today I'm going to focus a bit more on the intestinal manifestation. So one potential mechanism is that because this virus can also infect immune cells, so these immune cells can disseminate through the blood, for example, to the different part of the body that cause systemic manifestation, but this is still something to be further investigated. Regarding to translational on monkeypox virus infection in our group, so we more focus on the development of new model systems that you can understand disease, but also to develop countermeasures, because today we have vaccine available that is used for eradicating smallpox, so it is also effective against monkeypox, but it's not sufficient. So we are also trying to discover and develop new therapeutics. So this hopefully that can work together with the vaccine that to combat the crisis. And I will talk a lot about a so-called organoids model system. That's the main approach that we study many of the viral diseases actually. So these are called organoids, a kind of small organ which we can generate from one type of stem cell called human, especially because we are working on human disease. So we use human-induced pluripotent stem cells. And these cells, they can differentiate towards all kinds of tissue-like cell types, so they can form organoids. These are mini organ, but these organoids can also generate from tissue stem cells, because in our body, a different part of tissue, we have the resident stem cells, so they can generate organoids more represent the original tissue or organ. So very straightforward, because monkeypox is first a skin manifestation, so there's already a protocol developed to generate organoids, skin organoids from these human iPS cells. This is one approach. So this is already developed. So we tested whether these skin organoids can be infected by monkeypox virus. Indeed, you can see the green color here is the skin cell marker, and here looking at one bigger skin organoid, and you can see the red color. This is showing the virus RNA, which is expressed during the viral replication, and this is showing that these skin organoids can support very strong infection of this monkeypox virus. So I'm not going into detail because it's already published study. However, we also demonstrate that we can use this model system to test medication. So this antiviral drug was approved for smallpox and currently also used for some cases to treat mpox. However, two big clinical trials recently completed, they show that this antiviral drug actually not effective for treating monkeypox. So I'm showing here is that in the experimental model, we try to mimic different ways of treatment. So this is called early treatment, means that when the skin organ is infected with virus, same time treated with this drug. So we look at the readout. Here, look at the genome copies of the virus. You see a very strong reduction, because here we are looking at the log 10 reduction. And here we look at the infectious virus titer. Over 1 week treatment, we even hardly detect the virus anymore, the infectious titer, which is a very important marker for the antiviral efficacy. However, in clinical practice, actually, when you see the patients, usually it is already late. The disease is already onset. And we mimic this kind of situation. So first infect with the virus for 4 days, then try to treat with the medication. And you can see here, look at the genome copy. Indeed, you see after 4 days infection, then you treat, you have very minimal effect on the reduction on the viral genomic copies. And we see inhibition on the infectious titers, but this is also much less if you compare with early treatment, because only after long-term treatment you see the reduction. But at this time also, even without treatment, they still already see the reduction on the virus infection. So this probably can partially explain why this medication is not effective in treating patients, because you treat patients a bit too late. It's not at the early time of the infection. So the mechanism, I can't go detail, but these are some ongoing research. So I now move to another manifestation. This is more about intestinal manifestation. So quite some patients can develop diarrhea, and the more patients actually develop rectal pain and the inflammation infection in the intestinal system. And this is especially seen in the recent outbreaks. So this is a case that developed monkeypox disease, but also the intestinal manifestation, who died actually. So you can see in the intestinal tissue a lot of lesions developed. And we can do a staining on the monkeypox. In the lesion area, you see a lot of staining. This is a brown color showing the virus. In the distal part, you don't see the infection, so very specific infection. So this is showing that the patient can get infected in the intestine by the monkeypox virus. That's why we extend to use experimental models to culture these organoids from different parts of the intestine. Then we see the infection of virus, and over time you can see in a 1 week time this rapid increase of the virus genome copy in these organoids, but also the infectious titer in the supernatant and in the organoids. So this is showing the infection, and we can also see it by eye. For example, with the antibody to stain the monkeypox virus, here red color, you see very strong signal. And we can also see the virus by EM. And you can see these are very typical morphology of monkeypox virus in these two types of organoids. And you can see these are the viruses. So because these intestinal organoids, these are cultured from tissue, we can expand them very quickly. So we can even do a drug screening. So here we demonstrate with a specialized drug library called broad spectrum antiviral drug library. And these drugs are pre-selected, so they have high chance to against the virus. And we use a pipeline that we perform a screening. We include a positive control, which is known to inhibit the virus. And you see a subset of drugs that have an antiviral drug activity. And we extensively validate one drug, which is a clinically used drug. And you can see here this showing the inhibition of virus and this effect on the host organoids. So means this is a very specific, a strong antiviral activity. And we also perform the sequencing analysis. And here we only look at the virus transcripts within the total transcriptomics. And we can see this untreated, this is the treated group, and there's a very strong reduction on the virus genome level. And we also work on another approach, AI-based approach at large scale to discover antiviral drugs against monkeypox, but also other related pox viruses. And this is a pipeline that we have developed, the paper is submitted, so I'm not going to detail. And with this pipeline, I want to just show you one piece of the data. We find actually 2 clinically used anti-ICHR-25 drug. You can see they are very potent in inhibiting the monkeypox virus infection. And this is the experimental model that we validated from after we identified the drug candidates by the AI pipeline. In these two drugs, you can see the inhibition at the viral DNA level, and here we are looking at the infection titer reduction, and you can see even by the eye, this group without treatment, only the virus, and the red color here showing that inhibition on the virus replication. This drug is much stronger, and you can hardly see the staining on the virus.
He is a globally recognized specialist with decades of experience in the field of organ tissue and cell donation from transplantation, Professor Dr. Marty. He will join us virtually via Zoom.
We can't hear Dr. Marty, unfortunately. So I think somebody at RMI needs to turn on the audio.
Now you hear me? Now you hear me?
Yes, Dr. Marty, we can hear you now, or at least I can hear you.
I share the presentation again. If we look at the global observatory, the total number of transplants performed worldwide is only 172,000. That means 10% of the global needs. And why? Because only 45,000 people who die become utilized donors, 34,000 for brain death, and 11,000, that means 25% from DCD, donation after circulatory. Well, DCD was the beginning of transplantation. The first kidney transplant performed in 1962, the first liver, the first heart in South Africa, and pancreas. In the 60s, the diagnosis of death was done by circulatory criteria. After there appeared the definition of brain death in the 70s and the 80s, and we start to utilize donation after brain death. In some way, it's the bodies with the heart beating, and we obtain better organs and better results. But with the time, the number of these donors become less cancerophilic trauma by road accidents, less comorbidities, more older donors, and finally we start to think again, why would we go back to utilization of donors after circulatory? And that is what happened in the last years. In the 90s, we have improved the DCD donation, and then we combine both DVD and DCD in some countries worldwide. This is the registry worldwide of donation per million of population. In blue is donation for brain death, and in yellow that means DCD. And you see now represents with this 25% of the donation, 23% in 2022, 25% in 2023. But from all kind of donors, or from non-harvesting donation, in blue we call control DCD, category 3. The majority of countries do category 3. And a few countries do in yellow category 2, that we call uncontrolled. And mainly is Spain with 5%, Portugal, Italy, and other ones. Let me explain then the evolution in my country, in Spain, is a total number of deceased donors from DCD. And here in blue, we start doing a lot of uncontrolled, but now mainly in green, we do controlled DCD. The last year was close to 1,000, and a few of the uncontrolled, and 41 is we call combined euthanasia plus well, this is my region in Barcelona, all the hospitals who donate organs. And you see that in black-blue, there is the DCD donors, and in the yellow-blue is the DVD. So today, the DCD donors is the higher number of donation in average. 62% of the donors in Barcelona are from the donation after circulatory death, and 38% are donation after brain death. And that altogether means is 42% of our donors are DCD, and 30% are DVD and living as well. And that have all the increase of donation in all the last. And that allows us to do this total number of transplants, more than 1,400 for the 8 million inhabitants. There's 150 organs transplanted per million of inhabitants, and our waiting list become flat now. Well, this registry also shows in blue all the DVD donors worldwide, and in red, more countries start to do DCD. Here is a summary that Spain is 22 donors per million are DCD, followed by Belgium, also 50% of the donation in Belgium from DCD, US, United Kingdom, and I hope in the future more countries can join that. Maybe it's an option for Pakistan to start that. When we talk about DCD, mainly have two categories. One called uncontrolled, because mainly happen the death outside of the hospital, and we don't know when, or control, and that the death happen inside of the hospital, and also we can schedule. It's the same graphic inside of the hospital. We have the category 3 or control, is a patient who is futile to care, and we will drop the treatment on time to certify the death and then to make the perfusion of the organs. While the uncontrolled is a death who happened outside of the hospital. For this, my prediction is that 68 million people who die every year in the world, how many are potential donors? The first etiology of death is ischemic cardiopathy. And my colleague Nasser, you are more related with cardiology. That means 13% of that could be uncontrolled donation, controlled donation, or DVD, and I will show you how. While the rest, the cerebrovascular accident, who are in the ICU, ventilated, and so on, could be DVD or controlled DCD. I mean, it's the main etiology. In our region, encephalic trauma is only 1.73% of all potential donors. This is data from 2012, but is the number of cardiorespiratory resuscitation or death in the streets, 350,000 per year in Europe. It's 1,000 cases per day. The recuperated are 40%, but the rest are not recuperated. Only survival in the hospital is 15%. For this, I assume that the 600 not recuperated who remain outside of the hospital could be considered potential uncontrolled DCD. And the one recuperated, ones in the hospital, the ones who don't survive could be a potential control disease. Yeah, that is to show that it's a new source of donation with not all the problems of brain death and so on, which sometimes is difficult for countries like Pakistan. This is a study, a retrospective analysis of the national outside of the hospital Hispanic cardiac arrest registry. In this period of time, we registered 3,500 cases reported, and 181, 5%, fulfilled the criteria of uncontrolled DCD. I don't know if in Pakistan could be similar or in other parts of the world. And from that, 141, 4%, so 4% of this death on the street outside of the hospital become utilized controlled disease. If we transpolate this data, for example, to the US, where they have also out of the hospital cardiac arrest, is this number, 347,000, 5% of that could be eligible donor and 4% could be utilized donors. There is 17,000 eligible uncontrolled DCD not utilized in a state because the practice is not on. Well, with my colleagues, we published many years ago what is the pathway for organ donation. And the pathway mainly for donation after circulatory death could be, depends. You will drop the treatment or you continue resuscitation maneuvers after death is declared. You can have, we call eligible donor when medical is suitable for those organs and when death is declared. And we call actual when at least one organ has been retrieved. But important is to utilize these organs and when at least one organ is utilized. What needs legislation? For example, in Spain is encouraged and regulated. I don't know how it will be possible in Pakistan or in Southeast Asia. In Germany, for example, it's for. We have a law in Spain since 1979 that any dead person can be considered as a potential donor. And since the year 1999, also is the consent to make preservation in these dead bodies for the purpose to resuscitate the organs. Well, what happened with the families? Families understand the situation when they arrive, when they are there, when we talk with them. Because the issue is the refusal for DCD is only 10%, while the refusal when we talk a family about brain death is higher, 16%. Altogether, 14% refusal to the donation for the family is a very low refusal. Let me explain how that works. No? For example, the case of the uncontrolled donors is the rescue service around my hospital, 1 hour time by car or by helicopter. When they find a possible donor, they will prolong the CPR maneuvers, not for the intention to resuscitate the person because already have been declared dead, but to prolong the preservation of the body and arrive to the hospital. And one in the hospital will be officially dead, and then we can start the perfusion. And this is a case of finding. We bring the resuscitation team street or by helicopter to the hospital with a cardiopulmonary resuscitation, and finally we declare death. There will be a potential uncontrolled DCD. What happened with the control? This is different. Is that people we identify in the ICU, and it's futile to continue care, and the doctors decided to have a will drug treatment, to stop the treatment, and the family consent donation. And then we can combine all these issues, and after 5 minutes of no-touch period, we can declare this person dead, and we can start preservation thing. And that our team can go to other hospitals to do this procedure. Maybe not all the hospitals have the material, the technique, the experience, but we can mobile a schedule in each hospital around. Maybe in some cities or places in Pakistan also could be, The technique would do all surgically or also by Seringer technique in the ICU. You can place the cannulas in our law even before death declaration. We can prepare and put the cannulas. And after that, we have the death body with the cannulas in the aorta and the cava vein, plus the Fogarty balloon in the thoracic aorta to do the perfusion of the abdominal organs. But how antemortem intervention is possible to do, that will depend on the regulation and the law of your country. For example, in UK is more limited than in Spain. No? We can do X-ray, echocardiogram, blood samples, CT scan, blood transfusion, coronary angiography, put a guideline insertion. But we can do in Spain a full heparinization of the body and perfusion cannula insertion before death is declared for the purpose to have a good preservation of the organs. And what will be the best system of perfusion? Once in the past, we used to reduce the metabolic path, and we have to put the organs very cool at 4 degrees. But today, since 2000, we do the opposite. We do normothermic recirculation. We try to recover the metabolic energetic status by the technique of. And with my colleague, Ricardo Valero, we published in the 2000 that normothermic recirculation reduced the primary graft dysfunction of the kidneys, but also reduced the liver, the biliary tract damage produced by the ischemia. This is that after the withdrawal of the treatment or after the cardiac arrest, if we can put this body on the NRP, like the metabolite will be recuperated, and that is the time to retrieve the organs and to do that. And how is that the body looks? The body is absolutely death, declared death some hours before, and the body is perfused. Here the aorta, here the cava vein, oxygenated, 37 degrees and perfused. And the Fogarty is in the thoracic aorta, blocking the perfusion to the. Oh, but in 2020 we start to do also the abdominal, thoraco-abdominal normothermic recirculation. Why? Because we want to recuperate also the heart and the lung, and that is more specific. Well, important now is how to see the viability of this organ, because this death, body arrived dead, no medical records.
Thank you, Professor Marty. Now I would like to call upon stage Professor Dr. Abel. He is a distinguished professor of indigenous health and nursing in South Africa, Botswana. Professor Dr. Abel.
Assalamu alaikum. Good morning, everyone. Goeiemorgen. My engagement will be on co-opetition, collaboration, and partnership models in research. Now, firstly, the previous slide, I'm currently in Botswana, where I am at Boitekenelo College, but my in-depth research is run in South Africa at Durban University of Technology, which is a higher education institution that's over 112 years old. Now, the irony of Durban University of Technology is that it is a confluence, the Rainbow Nation, where we have predominantly the community of Indian descent and mixed with the other South African communities. So Pakistan would feel quite at home in Durban. I'm also bringing you the warmest greetings. I don't know whether a number of you know that Africa is the cradle of humankind. That is where humanity begins. And on my right side is the cave of the cradle of humankind, where the first human remains was dug up. And on the left side is the Big Five, which we all know. So warmest greetings from the continent of Africa, specifically South Africa as a country. Now there's a lot of did you knows this morning, but did you know that the first university in the world was started with a collaboration of Africa and Asia? How it started in Morocco, and the university is the University of Al Quran. It's still existing. That was the first university in the world. It started on the principle of madrasa on the African continent. Now that is a collaboration to look back on. Even if you look at the regalia was inspired by Fatma, the lady that got money from her father and started the university in the mosque in Morocco. So all regalia across the world, how we dress when we go to graduation, was inspired by a confluence, by a collaboration of Africa and Asia. Now, firstly, before we can understand the word co-opetition or the action of co-opetition, we need to understand what collaboration is. Now, the emphasis of collaboration is working with, of partnership is normally contractual, where we get into the partnership. And the easiest partnership possibly that all of us understand is the partnership of marriage. It's mostly contractual, written or unwritten, but the contract is quite clear and everyone knows what is expected from them, and that is equal and or whatever equality mean in our context. Then competition is when we contest and we have an opposition. A lot of times we think competition is unhealthy, but competition actually strengthens the product that we are bringing out. I would please not ask help. I'm an e-learning teacher and I like to operate my own things. Sorry for that. Now, what is co-opetition? Co-opetition is when we integrate cooperation and competition. As I said that competition is not unhealthy. There is a very healthy part of competition. However, competition can be destructive. Then when competitors work together for a collaborative gain, and the word or the concept of co-opetition started in the business world, and where big companies started to work together for mutual or bigger profit. And in co-opetition, there are rewards, but there are also risks. Now, just an example of the own research that I did is from my PhD, I looked beyond the PhD and realized that we have to develop a niche area, a theme, so that we move from there. So doing research in indigenous knowledge systems, which does mean local knowledge systems. What have people done before we were all colonized? What did we do before the Western health systems were actually enforced on us? So coming from a single PhD, we moved to a regional platform, which we called Siboka. Siboka is an African idiom that means that if you do not hunt together, you will not even catch a limping deer. So if you look at lions, lions hunt together in order to catch the deer, and they never hunt one. So that was the regional, and I'm working in South Africa, Lesotho, Botswana, Namibia, Zimbabwe. So the whole region, we are working together as researchers and indigenous communities in order to accentuate that we were before we were enforced in certain health issues. Then we are currently setting up the Afro-Asia platform because with at least 2 of the students in Pakistan, we started to do indigenous knowledge research. When we did research in Dr. Orang's PhD, we used the jirga as a method of data collection, but also therapeutic engagement with regards to obesity. And when we did Mr. Salman Alam's research, we look at integrating indigenous knowledge systems into the curriculum of nursing. So we have already built partners, but we look beyond only indigenous knowledge systems. We look at the capacity and the operationalization of research within the 2 continents at this stage. And continents, countries, South Africa and Southern Africa, the region, as well as Pakistan and India as a country, where another ex-PhD student of mine that have worked in indigenous midwifery is situated. So from a single PhD through co-opetition, because researchers by nature are in competition. Even when you have completed a PhD student, they are competing with you to become better than you. So you need to have the courage to accept and to build them and to allow them to stand on your shoulders. So the models of co-opetition that I propose through my 25 years of experience working with different researchers in different countries and different indigenous communities is a specified co-opetition model where you have a specific area which you work on, and after that area you then part ways. Normally, co-opetition in research, it is transdisciplinary research where we work with different disciplines and we bring out the strength. Then partial co-opetition, which is where participants become open to work together, and then inclusive co-opetition when the rapport is built, when the relationship is built, but very clearly in co-opetition, the rules of co-opetition, the obligation of each partner and the benefits are quite clearly stated. In a collaboration and a partnership, we can keep it a bit fluid, but in competition, we are quite clear because we know we are different institutions or we are different people, and we need to put it quite clear. So those are the models that we are using in competition in research. Now, just to say to you, between Pakistan and South Africa, the biggest competition on a lighter note is cricket. Pakistan know all our cricketers and they emulate them and they win. South Africa don't win anymore. We come either second or third. Now that is competition to the highest order. And when I started working in Pakistan, also another member of my community, Vernon Philander, joined the cricket team to be a bowler coach, and I'm proud to say he's also from my community, and our Pakistani community used them to win over South Africa. So that is competition. The rules are quite clear and the outcomes are quite clear. So on a lighter note, if they can do it in sports, we can do it in research. Now, if you look at the Code of Arms, and Ma'am Silay made the statement of united we stand, divided we fall. Between Pakistan and South Africa at least, our Code of Arms is coming from my language. I'm from the Bushman community where we speak a click language, and we say unity is power, which is pronounced in my language. It's on the Code of Arms in South Africa. The code is spelled wrongly. It's Ike, Ikara, Ike. That means together we stand, divided we fall. And if we as researchers can come together to make research a powerful kingdom. Thank you. Just to say to my colleagues, I'm done. My message is quite clear. I'm open for competition. And we had discussions with students in the previous session, and they say, how open is South Africa for us to start collaborating? We are very open. People don't know that we are more open than the other countries that are more developed, and our issues are very similar. I thank you.
Thank you, Dr. Abel. Thank you, Dr. Abel. Now I would like to call Dr. Junaid Sarfaraz Khan, who will be joining us virtually. He is the former Dean and CEO of Lady Reading Hospital. He is also a professor of medical education and an experienced oncoplastic surgeon. Dr. Sarfaraz will join us later due to internet connectivity issue. Now I would like to call upon stage Dr. Asad Ali, the chair and professor of Department of Community Health Sciences at Aga Khan University, Karachi.
Bismillahirrahmanirrahim. Assalamu alaikum, everybody. It's great to be here. First of all, I want to thank all the organizers for giving me the opportunity to come here and to attend. This is my second time attending this, and it's such a pleasure meeting all the faculty and the students. We just had a fantastic session in the morning of discussion, informal discussion, which I think is really the highlight. I think this conference is really putting Rahman Medical Institute and KMU on the map, and it's kind of identifying them as one of the key leaders of research in the country. We definitely need institutions, strong institutions, to uplift, and this conference is a great effort in that, so thank you. Can I have my slides? So what I'll be talking about is integrating community health approaches and translational research, and I think the best way for doing this is through a story. And what I want to share with you in the next 10 minutes or so is a story of how principles of community health and, right from the, sorry, go ahead. How things from from the bench to the bedside to the community, how they all come together. And the message I want to give you is how we can achieve strong things and deliver strong outcomes for our country by working together and by collaborating and by leveraging each other's strengths. So the story I want to tell you is that of the rotavirus research, which I think you will enjoy. So I don't have any conflict of interest to report. What I'm going to be talking about is our joint work related to rotavirus. So many of you know rotavirus is, it was discovered, detected in 1973, and basically it's a big cause of diarrhea in children. And what it does is it really, if your healthy villi look like those on the left, it basically destroys these villi. Your ability to absorb water really goes down, and you have profuse diarrhea. So overall, in terms of the causes of child deaths, obviously the biggest cause of child death, the top 3 causes of child death are, number 1, neonatal deaths, then pneumonia, and then diarrhea. So if you want to fix these, the biggest tool that we have in our armamentarium is of vaccines. So the question is, if we focus on diarrhea, what causes diarrhea? If you want to make vaccine against diarrhea, which germs, which bugs would you prioritize as to against which you will make a vaccine? So the first question to ask is, what are the causes of diarrhea in children? So what happened was that this very large study was done. This was called the GEM study, Global Enteric Multi-Center Study, where many different countries in Asia and Africa, they selected a community and did community-based, because when you do hospital-based surveillance, it's a biased sample that comes to you. So this was done in the communities where, if a child had diarrhea, we applied really the cutting-edge diagnostic tests, because otherwise when a child has diarrhea, we don't do the workup to really determine what is the cause of that diarrhea, which bug is causing this. But here, since we had a lot of resources from our research, we applied the cutting-edge diagnostic methods to figure out what is the cause of diarrhea, severe diarrhea in these different countries in the study sites. And what was found was that the number 1 pathogen that was identified was rotavirus in this age range of, this early age, 0 to 11 months, so first year of life. Then when we come to the next year, the second year, 12 to 23 months of age, again rotavirus was one of the higher bug that was causing diarrhea. And after we moved towards the older age range, 2 to 5 years of age, rotavirus was not the top pathogen, but still was one of the one of the major pathogens in there. So it became clear that you will get, most of the mortality happens with diarrhea in the first year. You will get the maximum bang for your buck if you focus on rotavirus. At that time, what happened was that, two vaccines became available worldwide, Rotarix and Rotatec. And, this was there. So, the question was, should we, Pakistan, apply these vaccines in our country? At that time, it was clear that the vaccine efficacy is not the same all across the world. So in high-income countries, the vaccine efficacy was, so this is based on, if you see the WHO, so this was based on, the left is the WHO mortality strata. So in countries with the low mortality, meaning more developed countries, there the vaccine was working much better, 85 to 100% vaccine efficacy. And in countries with the high mortality, the vaccine efficacy was much lower. So the question was, should we do this vaccine here? Is it going to be value? So, you have to balance, even if the vaccine efficacy is low, the burden of disease is so high, you will save a lot of lives. You will save a lot more lives when you apply this vaccine in developing countries compared to the developed countries. So we did this comprehensive study of impact of different dosing schedules on immunogenicity of the rotavirus vaccine in infants in Pakistan. And basically what we did is we gave the vaccine at 6-10 weeks, 10-14 weeks, and 6-10-14 weeks of life. And what we did find was the vaccine efficacy was indeed on the lower side. It was in the higher 30s, low 40s that we found in here. So as we kind of feared, the vaccine efficacy in Pakistan, when we tested it in Karachi, it was on the lower side. However, this was also the data that when countries have implemented this vaccine in their countries, the hospitalization of rotavirus gastroenteritis in children under 5 years of age has substantially decreased in the countries that have applied this vaccine in their place. So, and similarly, the mortality, the impact of rotavirus on deaths for all-cause acute gastroenteritis among children also had gone down in the countries that they have done it. So we were able to work with the government and kind of convinced them that rotavirus vaccine was introduced progressively starting from Punjab, but then in June 18 it was implemented all over the country. After that, now comes kind of a big collaboration thing that we said, okay, we have implemented it, but is it actually making a difference? So a network was created which was called Parwan Network, Pakistan Rotavirus Vaccine Assessment Network, which was a joint venture. This is kind of, how we are bringing things kind of from the lab side back to the community. So problems identified in the community, vaccine made, and now coming back to study its impact in here. So partner hospitals across the country were done in here, and these were the hospitals that were included in this original Parwan study. So this had from Karachi, from Lahore, from Multan, from Rawalpindi, and from Peshawar. So a good national thing, and this is when the surveillance was started. In some places, surveillance was done, in some places vaccine effectiveness, and then there was also a study to see if there is any interception, which is one of the feared side effects of the vaccine. So we did this, and this was a place where I'm very proud how the academic centers across the country came together under this banner of Parwan Network. So instead of everybody working in silos, if we were all working in silos, none of us could do this. But since we had trusted partners all over, people came together, and this study was done. And here the goal was to establish a standardized surveillance system for rotavirus, assess the impact of rotavirus vaccine on routine, assess the reduction in rotavirus-associated gastroenteritis, evaluate the effectiveness of the 1 dose and 2 dose of rotavirus vaccine, and also study the risk of interception. We didn't find any risk of interception, and this was the methodology. For the sake of time, I'll move forward. And what we found was the vaccine effectiveness was around 30% in children 5 to 11 months of age. 12 to 23 months was 14%, and in the after children older than 2 months to 5 years, this was less than 14%. So we were here, and at that time it was yes, the vaccine effectiveness is low. However, the number of children that are dying in Pakistan is so high that even if you save these many, with lower vaccine effectiveness as well, you are still making a substantial difference. So number of lives saved is still high, so we should continue. But then there was also a thought, what can we do to further improve the vaccine effectiveness so that more of our children can can benefit. So at that time, a thought was, should we do a Rotarix? So right now the vaccine is given in 2 doses at 6 and 10 weeks, and then it was, what happens if we should we give a booster dose as well? So a new project was done. So a phase 2 has been done in which a booster vaccine has been added at 9 months of age. And this is being done in select places. And I'm very happy to share the 2 places which have been selected for this model to give a booster dose of vaccine are 3 union councils in Karachi and then in Peshawar. So Karachi and Peshawar are 2 places where this project is being done right now. Provincial EPI diarrhea surveillance among less than 5 years of age is being done. Stool testing is done. And this is our current, the project is right now a collaboration, and these are the collaborating partners that are here. I would very much, now that I'm here, I would love to discuss kind of including the Rahman Medical Complex Hospital as well in this. So, the more the better in terms of the partners. And this is kind of what we are doing. So there is a vaccine, the booster dose vaccine has been introduced in select areas in here, and then this surveillance is right now being done to really to see what is the effect of this booster dose. Are we able to improve the effectiveness of the vaccine here or not? So a lot of work has happened, is happening. This is an example of multiple people kind of working together in this. So I want to kind of conclude. So a lot of work has been happening from our team. Dr. Tahir Yusufzai is leading this work in here. What I want to just say is to leave you with 3 messages. Number 1, impactful scientific and public health advancement can occur at the intersection of community health and translational research. When we do research, our purpose is to make an impact, and this is what we can do. Research is always a teamwork. It is never a single person, and we can achieve so much more by coming together like we have done in this project. And there are many, many opportunities. And conferences like these really bring different investigators together, and more opportunities kind of come up. And for you as young people, those who are here, you should build or join a network of trusted partners for a win-win relationship. There are plenty of opportunities. We have to solve our own problems, and we have to know that collaborating with each other is not just necessary, it's not just a good thing, it is a necessary thing, and we really can all improve our productivity by collaborating with each other in a fair manner, in a trusted manner. Thank you very much for your time and attention.
Thank you, sir. Now, Professor Dr. Junaid Sarfaraz will join us.
And a very good morning. It's a pleasure to be part of this wonderful mood. I think Rahman Medical Institute and the Rahman Medical Systems have done a great job in organizing this wonderful conference, and I'm really, really excited, and I'm thrilled as well as feel privileged to be part of this academic event. So my talk is on public-private partnerships and advancing global health, and I'm going to time myself as to finish my talk within 10 minutes. The focus of my talk is going to be on public-private partnerships, and global health is navigating a transformative era marked by unprecedented challenges such as pandemics, rising antimicrobial resistance, and persistent healthcare disciplines. And this is where public-private partnerships have emerged as a dynamic and effective mechanism combining public mandates with private expertise and efficiency. This presentation will delve into the structure, roles, and real-world contributions of public-private partnerships, emphasizing the growing importance in fostering sustainable, innovative, and equitable health solutions. Well, what is the need for these public-private partnerships in global health? The reason we need to focus on these public-private partnerships is because government mechanisms often struggle to meet escalating demands for research, infrastructure, and access to essential services. And PPPs bridge this gap by bringing together funding, knowledge, and operational support to develop scalable health solutions that benefit all socioeconomic groups. So WHO defines PPPs as structured collaborations aimed at improving health outcomes through shared goals, mutually agreed roles, and robust governance. So public-private partnerships focus on shared goals, pooling of resources, risk sharing, and transparent governance. Some forms of public-private partnerships include product-oriented PPPs, outcome-oriented PPPs, and activity-oriented PPPs. Examples include Global Alliance for TB Drug Development, Global 2000 Initiative, and Medicines for Malaria venture distributing antimicrobials. Traditional global health governance was dominated by nation states and intergovernmental organizations like WHO. But now the role of NGOs and civil society groups and multinational corporations is very important in advancing healthcare delivery systems and improving primary and preventive healthcare. And this evolution demands new models of transparency, stakeholder engagement, and accountability to protect public interests. Some major successes over the years have been the, Gavi, for example, which has been able to immunize over 1 billion children in 77 countries. Coalition for Epidemic Preparedness Innovation, instrumental in funding early COVID-19 vaccine, and NHS Innovation Accelerator has introduced digital health platforms and medical technologies improving patient care. Medicines for Malaria venture have over 13 antimicrobial drugs developed, pediatric-focused treatment, and significant reductions in malaria-related deaths in Africa. So that's another success story. And I think the public-private partnerships need to focus on sustainable development goals, which they have been doing so in the past as well. And our focus in developing these public-private partnerships in Pakistan should be on these sustainable development goals as well. There are a number of regulatory bodies that regulate public-private partnerships at the federal level as well as the provincial level. The one at the federal level is the Public-Private Partnership Authority. So the P3A sort of evaluates and approves PPP projects, provides technical and financial assistance, and coordinates with ministries, divisions, and provincial governments. These are some of the projects that they have done. And as you can see, their focus has largely been on infrastructure development rather than health systems improvement and healthcare delivery systems. So even though the private priority sectors include education, healthcare, and medical technology, but largely they have been focusing on infrastructure development. And the challenges at the federal level include complex regulatory environment, delays in approval and procurement, limited risk mitigation frameworks, lack of PPP expertise in some federal agencies, and political economic uncertainty affecting investor confidence. At the provincial level, for example, at the level of the province of Punjab, we have the Punjab Public-Private Partnership Act 2014, and the authority oversees and regulates all PPP initiatives in the province, coordinates with Planning and Development Department, and that its focus also has been on infrastructure development largely, but there have been some success stories in the health sector. For example, district hospitals operated by private partners, for example, in Rajanpur and Mianwali, and mobile health units and diagnostic centers. Here again, they're focused on process, and the challenges they face are quite similar to the ones faced at the federal level, which include resistance from public sector unions, inadequate project preparedness at the local level, capacity issues in local government institutions, and political transitions sometimes delay project implementations. When we compare federal with the provincial authorities and the projects, we can see that the challenges are the same, and the key areas that have been focused on are on the infrastructure development rather than healthcare delivery and research and improving healthcare systems. But when we compare it to the global health research advancement through public-private partnerships, we can see that at the global level, the focus is on healthcare delivery systems. The focus is on research and development in healthcare and medicines and immunizations, rather than just infrastructure development. And that is, those models at the global level seem to be more sustainable models with very different challenges. For example, where we see bureaucratic challenges in Pakistan, these are not the case at the global level. So key comparative insights include, as far as the similarities are concerned between Pakistan and globally, so multi-stakeholder involvement and financial innovation and focus on public benefit, but the differences are mostly localized and sector-specific in Pakistan, and whereas the global health research is transnational and innovation-centric, aiming for solutions to global epidemics, and regulatory and ethical complexity revolves around including bioethics, global regulation, and clinical trials, whereas in Pakistani PPPs are governed by domestic procurement rules and financial vetting issues. What we need to do from the global health research perspective is try to learn from them, try to emulate what they are doing, and also try to engage them and sort of adopt their policies within our system so that we can have better public-private partnerships with better efficiency of actions, as well as which are more product-oriented. Key benefits of public-private partnerships include enhanced resource mobilization, accelerated innovation, improved access and equity, capacity building, and risk and cost sharing. Whereas the challenges in implementing public-private partnerships have already been described, have been stated. These are regulatory barriers, conflicting interests, as well as financial uncertainty, governance issues, and equity concerns. So strategies for overcoming these challenges would be to identify clear role definition, broad stakeholder inclusion, regulatory harmonization, stable financing mechanisms, and ongoing evaluation of such projects. Some future directions would be public-private partnerships in digital health expansion, strengthened equity lens, sustainable development goal integration in public-private partnerships, as has already been stated, triangular cooperation models facilitating collaboration between donor countries, developing nations, and private innovations, and innovating financing models such as social impact bonds and health venture capital funds can drive investment. So recommendation for policymakers is to establish national public-private partnership frameworks and guidelines, develop PPP units within ministries of health, provide tax and legal incentives for health R&D collaborations mandate equity benchmarks in all public health PPP contracts and promote transparent public reporting and accountability mechanisms. So in conclusion, public-private partnerships represent a promising model for innovation, scalability, and equity in global health research. Their success hinges on inclusive governance, sustained funding, and a deep commitment to public health values. And by refining PPP models and drawing from global lessons, you can build resilient health systems ready for tomorrow's challenges. So these are some references, and thank you very much.
Thank you, sir. Now we would like to call Dr. Amna Amir, who is an associate professor and postgraduate program director at Ziauddin University, Karachi.
Assalamu alaikum, everyone. So I declare that I have no conflict of interest. Okay. Everybody showed something from their institute, but I wanted to show my vision as a researcher. So I wanted to lead through research, inspire through teaching, and create a legacy of knowledge that transforms lives. That's what my motive is. So while selecting this topic for allied health sciences, because I'm a postgraduate program director for allied health sciences and I've been associated in research for past 14 years, I thought of why not to have an overview on why do we need a transformation in the translational research. Because initially it takes, or it used to take before COVID, almost 17 years for only 14% of scientific discoveries to reach that clinical practice. And do you think that in this digital era, we can wait for another 17 years? I don't think so, we can. With the increase in life expectancy globally, we know that this era, the decade of healthy aging, has come abroad. And WHO is taking quite keen interest, where the life expectancy from 2000 was 66.8 years, which has now increased to 73.4 years. And this, if you look at Pakistan, it is going to drastically increase as well. That means an entire decade would be in the healthy aging. So this is actually a good news for all the allied health professionals. So you have a lot of work coming up. Currently, there was a WHO rehabilitation needs estimator that stated in 2019 that there are almost 340 million people who were living in 2019 years in disability. That means that you need rehabilitation for 1 in every 3%, and he could benefit. That makes 2.8 billion people in the current existing situation. That means only in Southeast Asia, you could provide benefit to 630 million people, which is actually highest in the entire continent. So why does it matter? Obviously, the global burden is increasing after COVID. So that means rehab specialist, you have a lot of work to do. So as we aim for longer, we need to live healthier lives, and digital health tools will create remarkable options for you. So you do not need to work with your hands. Like as physios, we used to do a lot of manual work. As speech therapists, a lot of interactions were going on. As clinical psychologists, people were striving to have one-on-one sessions, but things have changed and will be changing. There are a number of subspecialties that has been claimed by UK, USA, Australia, and it actually differs for Pakistan as well. So there are a lot of allied healthcare professionals, A few of them I've written. There are a number of them that still are allied health, but they're not mentioned here. But this is as per NIH UK. So what do we do? Or how can we create a contribution? Or how can we create a difference in your life? So what we do, we help you for activity participation. We help you for activities of daily living. So you can communicate in the community, or you can participate in the community. You can live a healthy life. You can have a lot of mental, physical, psychological well-being, so we can actually fulfill the SDG goal of good health and well-being. Just to give you a brief structure of Ziauddin University, where I came from, because we have a quite big structure for Faculty of Allied Health Sciences. So these are all the colleges that we cater at Ziauddin College, where occupational therapy and pediatric medicine are two innovative subspecialties that is only catered by Ziauddin University. So how has the transformation taken place? The parallel bars, very common for stroke patients, have taken place by robotic exoskeleton. To be very honest, we don't have that in Pakistan, but people from biomedical engineering have formulated, and they are in process of formulating it as well. So we do have tele-rehab platforms thanks to COVID. We do have virtual realities, and to be very honest, we have a lot of theses coming up with virtual realities, especially in neurophysical therapy, neuropsychology. Why is that? I mean, why suddenly we came to technology? It was in 2017 when there was actually shift from subjective to objective approach in allied health, where people started using Apple Watch. I think everybody had it almost 10 years ago. But there were some of the activity monitors that we were using were research-based and some were consumer-based. Obviously, the reliability was completely dependent on where they are placed. So if you are wearing an active ball on the thigh, that means that it will give you the best reliability or excellent reliability. Whereas when you are having your Apple Watch, it gives you a better reliability, whereas a Samsung watch would not give you that reliability. So it all depends on the placement of the sensors. We have a lot of national evidences for the field of physical therapy. But to be very honest, and these are all the trials that are being conducted. We don't have reviews only, we have trials that are being currently conducted, and a few of them, or a lot of them, are being conducted at Ziauddin College of Physical Therapy. Occupational therapy, new blooming emerging techniques, and our students actually in their assistive technology courses are formulating different assistive technologies where they're making sensor mats, where they are making spoons for the disabled, where they have Dexty Trovo. So there are a lot of technological advancement there as well. National evidence is not suffice. We have reviews and we have urge for these. Let's talk about human nutrition. However, this is gaining a lot of popularity, but still we need, and we are having online apps as well for nutrition, but reliability is still compromised in Pakistan. So wanted to check if we have any studies related to it. Unfortunately, we only had global data for it, not national data. For speech, very well developed all over Pakistan. So now the PCS's boards are being taken up by the AAC devices. So even the autism, because it has taken a bloom, ADHD has taken a bloom. So people are using tablets, however, it needs to be dealt case-to-case basis. A few studies, in fact, this is the area where I would like to highlight for the allied healthcare professionals. They are working in the clinics, they are working in the hospitals, but they're not documenting it, which is a shame, because there's a lot of clinical work that has been conducted since 2000, but the trials are not, I couldn't find trials there. However, global evidence is there. So clinical psychology, the most favorite one of mine. If you want to just talk to these AI-based technologies, they give you answer, they reply you, even if you're in a sad mood. There are evidences, unfortunately, not nationally. However, clinical psychology is very well developed in Pakistan. The new one, emerging one, striving, but still with an aim that, yeah, one day we will be going for 3D printed models as well. What are the challenges? We all know that the laboratory research and the clinical application, they both are different. So there is a dead valley. Then we know that there are changing regulations every time a new policy comes up, every time we have a new government, every time we have a new council. So I hope we are settled now with the Allied Health Councils. And what is taught is actually not practiced. So globally, digital health is growing, almost 37%. However, with allied healthcare professionals or in the fields of allied health, it is still fragmented. So I don't know how long we take, but I have a courage, and I hope that we do integrate the strategies. We quickly, while the LMICs are facing challenges in their infrastructure, workforce, but I think we can create magic here. So good luck to all the allied healthcare professionals.
Dear chairs, we request your brief concluding remarks, please.
I'm Professor Fazal Subhan, and basically I'm a pharmacist pharmacologist. Today we have seen, so many talks on different areas, in different areas. The first talk was on the smallpox and monkeypox and the development of different antiviral drugs and developing different models. That is one of the important model was the organoid model, the intestine, and the testing of different drugs on that model. And the professor, talked a lot in that area with several examples. It was really a very good talk presented by him. He also talked about some of the antiviral drugs and their side effects, and discuss in length, that. So I appreciate, that lecture regarding, the antiviral model and the new drugs development. Then another talk was from Spain, by Professor Marty, who talked about the donation, the organ donation in two different conditions. One, the donation after brain death and donation after cardiovascular death. We know that these organ donation is not very much common, in Pakistan, but it is, very much common in other countries. and we have too many people waiting, for the organ, but the donor are very small number of donor. So these two models, he talked, on the cardiovascular death and the donation of organ. I'm not sure, which type is more favorable to the recipient, but I can see, initially, it was practiced, in the brain death model, and the organ, transplanted to different recipient. And the other model, the cardiovascular model, it has some disadvantages in comparison to the brain death. He talked about the cardiovascular death and the donation of the organs. He also talked about, he presented the data from different origin, and also very picture, of the surgery, which was very interesting. The important, of this, because this is a new area in Pakistan, we have several problems regarding, the donation of organs, which may be legal, also may be political, may be religious, and maybe ethical, several factors, influencing, this process. But anyway, this is going on, and it is, it was really a very nice talk, and I appreciate that, the most. Then we have got, another presentation, by Dr. Abil from South Africa, and he talked about, in a very nice way, about the collaboration, partnership, and cooperation in translation research or translation science. We understand, that the translation research will require so many different categories of expertise, and it is not, the job of a single person or a single organization or a single area which can conclude, this translation research. And for that, if we see, that initially starting, work in the labs, and then moving that to the clinical trials, and from the clinical trials into the post-marketing surveillance, and we see the translation science, cover, both, the preclinical and the clinical trials, all, covered by the translation. So here, we have, these different, cooperation, from different person. So collaboration and partnership and cooperation is a must, to get, market the drug, or bring a drug, from the labs to markets. It was a nice presentation, and we appreciate, that presentation. Then Professor Junaid, from Islamabad, he talked about the public-private partnership, and as you understand that it is not only the job of government to go through, all these, costly procedures, always, the public and private partnership is essential, for a successful completion of any project. And he talked in length about that. He gave a lot of data in that. And then he also talked about the problem arising, in the public-private partnership, and that is, related to regulatory problems and also the ethical problems. We talked in length about that. Then Dr. Asad Ali, he talked about the community health approaches in translation research. He gave, the example, one example involving community, and he talked about the retrovirus, which he talked in detail, and that, that the research conducted in the community, and the vaccine developed, and then a booster dose, vaccine developed, So this was a nice, way to coordinate, community and the health approaches. We like, that talk, very much. Then Dr. Amna also, talked about, the allied health sciences, the digitalization in translation research. And we know that now, it is very much, that the things are moving, toward the digitalization, era. And the things become now easy, but sophisticated also. It is very much, to know about, all those equipments, and to forward and to see, development in that area further. So that was, the last talk, which, the audience, can ask question, I don't know whether, the presenters, they may be available or not, but we have, the session open now.
Okay, so I'll just have a very brief comment on it because Dr. Fazle Subhan did justice to each and every talk. I'll just ask a few questions from the presenters who are available in this particular session. Dr. Aibel, just a very small question that I just wanted to ask. You gave us a number of models of cooptation, and you said specified model, partial model, and then there's an inclusive model. So which models you have used to the best of your, which model is the best of it? Because according to my knowledge, whatever I've heard about, you told us, the inclusive model is the best of these. So you have worked on all the three models? Okay, so
Yes, I've worked in all three models. When you start a relationship, the specified model is more safe because trust needs to be built between the collaborative researchers. And specifically working with researchers from different countries, there's different issues of trust that need to be breached. But it invariably moves into the partial and the inclusive model. And almost after 10 years, the inclusive model emerged. So the first 10 years, we have worked from the specific to the partial model. But after 10 years, when you work together as research I don't want to say partners, but participants, because we make use of different expertise, the inclusive model emerge.
thank you so much for the explanation. I think it clarified what I had in mind. I also have a few questions for Dr. Amna and Dr. Asad also, but I've been told by the organizers that we are short of time and we need to move on to the next session. So I'll ask you individually those questions. Thank you so much for all the enlightening talks.
Thank you, ma'am. Now I would like to call Dr. Nasir Ahmed to present a token of appreciation to our distinguished speakers and chairs. Dr. Abel. Dr. Asad Ali. Dr. Amna Khan. Professor Fazal Subhan. Dr. Naila Ira Mahadi. Thank you, everyone. The closing ceremony will begin in 15 minutes. Thank you.
tea is served at 6th floor. Kindly go for tea. And 8th and 6th floor.
The students are requested to join at 6th floor 40 and the professionals and guests are requested to join at 8th floor 40.
अस्सलाम वालेकुम नहीं
Assalamu alaikum everyone. Assalamu alaikum. Assalamu alaikum. Assalamu alaikum. Assalamu alaikum. थोड़ा ऐसे होता है.
गलती नहीं लगोगी ज़्यादा शेर ताना सफ़र ज़्यादा शेर ताना सफ़र मतलब अगर यहाँ हरू शुक्रवार तक कर तो देखिए ना अभी देखो मैं ठीक ना अपल मर करे ऑलरेडी एक्सपीरियंस है तो नहीं मिले आप आज की भी चलो तो नहीं मिले हाँ वाच भी वाला Niște măsălă cum mată, vezi, nu știu, nu mai este vrândă, dar la. briefly, ma'am.
Assalamu alaikum everyone. Please, it is requested that you take your seats. Our chief guest will be arriving any moment. Please take your seats. Thank you.
बंदों को कंप्रेस करो ताकि साइड पे खाली रहे जितनी इसमें दोस्त आ रहे होते हमारा क्या फर्क पड़ता है Jantar susuka sani. Sanuri, na wali da da da. Sempre que toda mas na reserva que deixa. Sorry, अगर भी हम मेंस की चीज़ यहाँ पास ही बस लैंड सी हॉल का ना सी होगी
Assalamu alaikum everyone. Our chief guest has arrived. He'll be arriving soon to the hall. Please get seated because we're going to close the doors of the halls. Thank you everyone.
Ladies and gentlemen, our chief guest has arrived. Please give a big round of applause.
Respected chief guests, dear speakers, panelists, faculty members, and participants, Assalamu alaikum and a very good morning. It has been truly a great honor for me, Dr. Gurmeena Masood, along with
Dr. Maheen Khan,
to serve as your host for this very special event, ICHR-25, organized by Rahman College of Dentistry under the esteemed umbrella of Rahman Medical Institute. The theme of this year's conference, From Discovery to Impact, Strategies for the Effective Implementation in Health Research, has been the guiding light of our discussions. It has reminded us of how important it is to translate research into real-life application, solutions that can genuinely make a difference in people's lives. Before we formally close the conference, let us pause for a moment to reflect on everything we have experienced together. Over the past few days, we have been a part of an incredible exchange of ideas and knowledge. From the insightful pre-conference workshops to the powerful keynote speeches, engaging panel discussions, thought-provoking abstract presentations, and dynamic scientific sessions, each moment has offered us something valuable. To formally begin the event, we would like to start with the recitation of the Holy Quran. For this, I would like to request our esteemed religious scholar and professor, Dr. Abdul Ghafoor Saab. Please, sir, join us on the stage.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم يا أيها الذين آمنوا إذا ضربتم في سبيل سبيل الله فتبينوا ولا تقولوا لمن ألقى إليكم السلام السلام لست مؤمنا تبتغون عرض الحياة الدنيا فعند الله مغانم كثيرة كذلك كنتم من قبل فمن الله عليكم فتبينوا إن الله كان بما تعملون خبيرا صدق الله العظيم शुरू अल्लाह के नाम से जो बड़ा मेहरबान निहायत रहम करने वाला है। ऐ ईमान वालो, जब अल्लाह की राह में जा रहे हो तो तहकीक कर लिया करो, और जो तुमसे अस्सलामु अलैकुम कहे तो तुम उसे ये मत कहो कि तू मोमिन नहीं। तुम दुनियावी ज़िंदगी की असबाब के तलाश में अल्लाह ताला के पास इस सिलसिले में बहुत सी गनीमतें हैं। पहले तुम भी ऐसे ही थे, फिर अल्लाह ताला ने तुम पर एहसान किया, लिहाजा तुम ज़रूर तहकीक और तफ्तीश कर लिया करो। बेशक अल्लाह ताला तुम्हारे आमाल से बाखबर है। अल्लाह पाक हमें अमल की तौफीक अता फ़रमाए। व आखिर दावाना अल्हम्दुलिल्लाहि रब्बिल आलमीन।
Jazakallah. Before we proceed further, I kindly request everyone to please rise for the national anthem.
Ladies and gentlemen, it is an honor to invite a visionary who has not only pioneered dental services at Rahman Medical Institute, but also has been instrumental in laying the foundation of Rahman College of Dentistry, Professor Dr. Ghulam Rasool, who began his clinical journey at RMI in 2002 along the founding team and has since remained a cornerstone in the institution's growth and excellence. With a career spanning over 35 years in clinical practice, teaching, and administration, Dr. Ghulam Rasool is an orthodontist by profession, a fellow of the College of Physicians and Surgeons Pakistan, and a seasoned medical educationist with an MHPE degree. He has served as principal and dean at Haber College of Dentistry and currently leads as the principal of Rahman College of Dentistry. He also holds the prestigious position of Dean of Orthodontics at CPSP. An accomplished academic who has over 70 research publications to his name, has served as editor of JKCD and is currently the founder-chief editor of JRCD. He has successfully organized several national and international conferences, including 2 international conferences on health research. We are truly privileged to have his continued support and presence at ICHR-25. Please join me in welcoming Professor Dr. Ghulam Rasool to the stage.
Bismillahirrahmanirrahim. Honorable Chief Guest, Dr. Muhammad Ali Saif, respected speakers, guests, colleagues, dear participant and student, Assalamu alaikum. Today is a great day. We accomplished a great job. We made a history of record gathering of intellectual at this campus. Today we gather here for closing of the 3rd International Conference on Health Research, ICHR-25. I must admit, there is a special energy in this hall, one that speaks of accomplishment, connection, and renewed purposes. Over the past few days, we have not only witnessed a conference, we have been part of the mission ICHR-25. It was more than just a series of session and presentation. It became a vibrant forum. It brought together diverse voices, clinicians, researchers, educators, policymakers, and students, all unified by a shared passion to improve human health through knowledge, science, and collaboration. I feel proud to say, without any hesitation, that ICHR 2025 was a resounding success. This conference received overwhelming participation, both in number and in depth of engagement. Sir, I want to bring in your knowledge, this is the record participation in ICHR-25. Very early we got more than 1,700 registration in this conference from across the country, not only in the country, but from across the globe. We received a record number of abstracts, up to 500 abstracts. This is a record in the Pakistan and even in the world, that for this single event we received 500 abstracts. For me personally, this edition of ICHR holds special meaning. As the patron of the conference and principal of Rahman College of Dentistry, I have seen this conference grow from an idea scribed in a notebook to an event that now proudly stands among the most respected academic gathering in our health education landscape. I can say this is exactly what we had envisioned as a mission a vision statement of the college and RMI. This is a true reflection of the vision of the founder of this RMI education, Professor Dr. Rahman. I must admire his dedicated efforts and support to the team of ICHR-25. The whole RMI management was behind us. They supported in each and every aspect, and today we are celebrating this event with greater success. This is because of the RMI management. I hope the chairman of RMI Education will be enjoying this event because it is a soothing for his thought process that he envisioned 30 years back to come here and enlighten the education and healthcare in the province. This is a great honor and contribution for the region. I am proudly said to be the part of RMI education. RMI healthcare along with the RMI education, and this is the third chapter we had opened, RMI research. And I think that we are leading in the health research, not only in the province, but in the country. RMI or management committee, they were strongly committed and they worked hard behind the scene, made every moment of this conference seamless. Our dedicated faculty and reviewer, their guidance ensured the academic strength of this conference. All the RMI support department, they have struggled a lot for the success of this conference. And the last and not the least important is the RMI education and their students. The student enthusiasm, curiosity, commitment made ICHR-3 feel alive. One moment that will stay with me is seeing young scholars confidently presenting their first research, standing side by side with the seasoned professional. That is what ICHR is about, creating space for everyone, old and new, to contribute meaningfully to the future of healthcare. As today we close the conference, I want to remind all of you that this is not the end of the conference, it is the beginning of many new conversation, collaboration, and commitment. Let it shape policy, influence the practice, and inspire innovation in the healthcare. Thank you once again from the core of my heart for being part of this journey. ICHR 2025 may be ending, but the impact we create together, that is just the beginning. I'm really grateful to our chief guest. He managed to come on a very short notice, but he honored our old memories. He is my college mate as well, and I'm proud of him, really. May Allah guide us in our efforts, bless our work, and help us to serve humanity through knowledge and compassion. Allah हमारा सबका हामी और नासिर हो. Pakistan Zindabad, RMI education Paindabad.
Thank you so much, sir. Mr. Shafiqur Rahman's vision and dedication to advancing medical research and healthcare in Pakistan are reflected in initiatives like ICHR, which continues to set new benchmarks for the delivery of healthcare and research in our country. It is my honor to introduce him, the key figure whose leadership continues to drive the success of Rahman Medical Institute and the ICHR conference. I'm truly honored to welcome Mr. Shafiqur Rahman Saab, the esteemed CEO of RMI. Sir, please.
Bismillah ar-Rahman ar-Rahim, and a very good morning, Honorable Chief Guest, Mohammad Ali Saif Saab, distinguished guests, colleagues, students, and dear friends. It's so wonderful to be joining you here on this momentous occasion. And as we draw the ICHR-25 to a close, I want to begin with a very simple truth. Pakistan does not suffer from a knowledge deficit, but we do suffer from an implementation crisis. Over the last few days, we have seen research that have been presented that could truly change lives, maybe even save them. But unless those discoveries are translated into action and delivered to the people who need it most, they will remain just that, discoveries. Shelved in journals, stuck in policy drafts, lost in translation. That is why the theme for this year has been From Discovery to Impact. From discovery to impact is more than just a headline. It is a call to action, it is a challenge, and it is a shared responsibility for all of us. As we celebrate the achievements of this conference and many other events such as this, I must ask, why would the mother in Parachinar feel the benefit of the insights we have shared? Will the trauma patient in Swat truly experience safer care, or will the child in rural Balochistan have access to better treatment that is informed by research? If not, then we have fallen short. Because research that does not reach the underserved is not worth the paper it is printed on. Many of the health challenges of the developed world, many of these health challenges are those that the developed world has addressed many decades ago. But unfortunately, they're still claiming lives in countries such as ours. It is not because we lack the knowledge, it is because we lack implementation. Over the last 2.5 decades, RMI has been investing in the future of this province, despite so many challenges. Alhamdulillah, I feel it has come a long way. We've made meaningful contributions to healthcare delivery, to education, and now in research as well. And although we are still a group of colleges, technically, events like ICHR and infrastructure such as the building that you see right here are testimony to our intent, our vision, and our commitment to progress. However, I must respectfully express that sometimes continued injustice does make us feel let down. For nearly a decade, we've been actively working to strengthen our collaboration with leading institutions globally, to further enhance the impact for our province, for which we have tried to secure a university charter. Meanwhile, institutions with far lesser credentials in the recent past have obtained this charter in the other provinces of Pakistan. And yet, here we are still waiting. It is just not RMI that is being held back. It is the students, it is the future of this province, it is the researchers in this province that are being deprived of an even better education ecosystem. We do not require any favors. All we request is for fairness. We're not seeking shortcuts. All we seek is recognition. Recognition for the work that has been accomplished and of the greater contributions that are yet to come, inshallah. Regulatory bodies such as the Higher Education Commission, the Pakistan Nursing Council, the Pakistan Medical and Dental Council have already recognized RMI and its contribution in different spheres and has been rated as one of the highest rated institutions in the country. Let the next chapter of RMI be written in the form of a university charter, not for prestige and not for privilege, but for purpose, for the thousands of students whose future depends on the decisions that we will make. Once again, my gratitude to the Honorable Advisor on Information for joining us despite a very busy schedule, to all the speakers who've traveled long distances, and to all the delegates who've made this conference a success. To Principal RCD, Professor Ghulam Rasool Saab and Dr. Nasir Ahmed Saab, thank you so much for all the efforts and that of your team members in making this possible. And I know while this makes many of my team members quite nervous about the commitments that we announced for next year, I really hope to see all of you next year with this building fully complete at a much better edition of this conference and an even greater participation both nationally and internationally. So let's aim high because our region and our people deserve nothing less. Thank you once again for your belief, your brilliance, your boldness, and let us walk out of here not just inspired, but mobilized. Let's stop waiting and start building together. Pakistan Zindabad, RMI Paindabad. Thank you.
Thank you so much, sir. It is a true honor for me to introduce the patron-in-chief of this conference, the chairman of RMI and a pioneering figure in cardiac surgery, Professor Dr. Mohammad Rahman. With more than 50 years of experience, Professor Dr. Rahman is internationally recognized for his groundbreaking work in cardiac surgery and his leadership in advancing healthcare in Pakistan. His visionary approach has not only positioned RMI as a hub of medical excellence, but also continues to shape the future of healthcare and research in the region. Ladies and gentlemen, please join me in giving a warm welcome to Professor Dr. Mohammad Rahman Saab. Please, sir, join us.
A'udhu billahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. Honorable Chief Guest, Muhammad Ali Saif Sahab, dear colleagues, friends, students, and the foreign delegates especially, Assalamu alaikum. As I mentioned earlier in the last meeting that RMI was my mission 2. I started mission 1 in Karachi in '75 to establish cardiac surgery across the country. It took me nearly 30 years to establish cardiac surgery in children, adults, and everybody. And then I decided to start with the mission 2 that it was in Peshawar. People are saying that you did like this, how did you do it? I said, no, it's not me. I am the executor, karne wala Allah hai. It's from Him that we are just doing it. Your intention should be good, your aim should be specific, and you should do something which is in the benefit of the humanity. Let me thank all the delegates, especially from abroad, to come all the way and contribute their knowledge, experience, with our other participants. I hope your stay was comfortable in Peshawar and you were looked after properly. The aim of RMI is not only to establish clinical side in different specialties like cardiac surgery, cardiology, other specialties, transplant, etc. But the next important thing is to develop the research program. It's the research which we need it right now, not only for the treatment, but also to do something in preventing the diseases. If you remember, most of the pioneers in the medical field, like establishing antibiotic, penicillin, they started treated thousands of people like this. Similarly, when the patient has a lot of infection, throat infection resulting with due to streptococcal infection, lots of patients had small children, everybody had heart disease. And I still remember when I started cardiac surgery, the youngest heart of patient that required heart valve replacement was a 9-year boy. So with the research and the help of medical education, the rheumatic heart disease has come down tremendously. Similarly, the next stage is coronary artery disease, which is an alarming challenge for us. It is spreading across the country. And again, this preventive measure in our knowledge through media, through the conferences, the awareness has become more important in the public, with the result that coronary artery disease is at least stable now, and we can look out to the patient with the maximum health care and prevent the disaster from heart attack and prolong their quality of life, and also at the same time give them a better living and work capacities. Research is important again. If you remember, in the early days there was smallpox, tuberculosis, and it was because of these vaccination, the prevention, which stopped all those horrible diseases. Even similarly, like other diseases, we had recently this corona, and we needed again like flu and other infection. So we can only do that by research. If you don't do research, then you have to face these challenges and epidemics all the time. Similarly, now we are facing another disastrous disease in our province particularly, and that is cancer, which is spreading like anything. It's not only cancer, but because of my opinion, because of this Tora Bora nuclear waste product which was used during Afghan war, is causing a lot of congenital anomalies in the patient, in the form of brain, in the form of mental health, in the form of congenital heart problem, and so many diseases. For that, again, we have to think about the prevention, how to do it. And again, we need a lot of experience and research work on that. I think what we should do, we should follow the footprints of our senior most people who worked hard and tried to decrease the incidence of various infectious diseases, communicable diseases, and non-communicable diseases in our country. With these few remarks, I would like to thank you all, and I hope you enjoyed your stay here, and wish you good luck. Thank you.
Thank you so much, sir. It is my distinct honor to invite to this stage a highly accomplished scholar, statesman, and public intellectual, Barrister Dr. Muhammad Ali Saif Sahab. He has served the nation in numerous prestigious capacities as a senator, federal minister, and currently as the advisor on information to the Chief Minister of Khyber Pakhtunkhwa. He also holds the distinguished position of Secretary General of the International Parliamentarians Congress. Academically, he is a towering figure holding 3 PhD degrees in law from the UK, Germany, and anthropology, as well as multiple postgraduate qualifications including LLMs from London and Essex, a diploma in human rights law from France, and masters in political science and philosophy. He is also a barrister at law from Lincoln's in UK. Please join me in giving a warm welcome to Barrister Dr. Muhammad Ali Saif Sahab.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Saab, Dr. Rahman Saab, for providing me with this opportunity to address such a luminous gathering of scholars, students, health professionals, people dealing with research. Indeed, research is a instrument which is used in the discovery of knowledge. It's not just an important human endeavor in this context of creation of knowledge, but it is also a sacred duty, the duty of a human being conscious of his duties to the mankind. And also, as a Muslim, if I speak for my own faith, yes, indeed, research is an obligation of all Muslims, all Muslims in the search of knowledge, we are duty bound to explore the boundaries of knowledge to the maximum limit that we can. That is the injunctions of our Holy Quran and the instructions of our great Prophet Muhammad, peace be upon him. Knowledge indeed is a sacred duty because it serves the civilizations. Civilizations are born and civilizations are destroyed. By the process of knowledge, by the utilization of knowledge, by using knowledge to benefit mankind, and also they go down the drain. They're destroyed when knowledge is misused, knowledge is not utilized as per its requirements. So, having said this, researchers, since you people are involved in the very important, utmost, cardinal duty of exposition and exploration of knowledge, indeed, reason, as we say, is the foremost key in this process. Reason guided by rationalism to discover hitherto unknown boundaries of knowledge which the creator of this universe has, in a way, left there for us to explore. Although I'm not supposed to be talking about what I'm saying right now, but I believe that since I've been hearing the word research, the term research repeatedly, these are the thoughts that just came to my mind while listening to the illuminous speakers before me. I believe that a few words on this topic are essential in the context of this particular gathering, because when I think about one of the verses of the Holy Quran in Surah Zariyat, Allah states that I have created this universe and it is ever expanding. It is in the process of expansion. And when an entity is in the process of expansion and it is ever expanding, it means it's not static. And when something is not static, it means there are hitherto unexplored venues that requires to be understood, that requires to be discovered. And then whatever you learn from that discovery process to be utilized in the betterment of mankind, but at the same time in the promotion of that process as well. I believe it was this approach which has influenced the thinking of mankind. The intellectual faculties have been challenged throughout the history, all ages, be it the religious explanations of the phenomenon of nature or scientific discovery into rationalizing those phenomena. I believe it's a long process going back centuries, thousands of years. And today we are sitting at such a stage in human civilization and in human progressive evolution that there are more questions to be answered. There are more venues to be explored. And for that, I believe the entire human experience in this context is at our disposal. The issue is, are we intellectually capable of exploiting the resources that we have in a way that benefits humankind, that speeds up the process of evolution in the right sense. Historical materialism is a philosophical system which believes in the development and progression in both material and non-material contexts. Hegel, the Western philosopher, called it the dialectics, the process of dialectics, dialectical materialism. And if we look at our lives at the moment, I believe we are just the product of those processes of dialecticism. At the moment, we are struggling to find answers, and in the process, we confront more questions. And then we try to answer those questions and we come up with more questions. But this is how nature and the creator of this universe, the Khaliq-e-Kainat, has probably engineered this universe. And we are doing nothing but following the dictates of nature when we are exploring knowledge. Rationalism, a very important key in this respect. Muslims, as Muslims, I believe that Allah has made us duty-bound to explore knowledge and to acquire knowledge. And the Prophet once said in one of his ahadith, he states that knowledge is the forgotten heritage of mankind, but Muslims especially. And all Muslims are duty-bound to explore and find it wherever they can. I believe this is what our duty as human beings and as Muslims is. But why are we, like as mentioned earlier before me, or what the speakers spoke about, research, knowledge, but lack of implementation. I believe there is a gap in policy and implementation. And that gap is not for any other reason, but because of the defective system of governance that we have in mostly underdeveloped countries or developing countries. We are faced with the challenge of how to implement our thought processes in actual practice. This is not just in the context of healthcare. This is not just in the context of medical sciences. We are suffering from this malaise, from this systemic defect in all our disciplines of life. It is because of another reason as well, that the more you grow knowledge, the more you create knowledge, indeed it leads to the development of and strengthening of civilizations. But at the same time, it is affected by negative powers as well, by negative forces. And those negative forces tend to turn it, divert it towards certain interests that are probably inimical to the values of mankind, like market economy. We are living in an age where money is becoming everything, where material interests are dominating our moral obligations. Our mindset is engineered in a way that it thinks of material benefits rather than benefits that may collectively contribute to the development of human beings. We tend to focus more on material gains rather than spiritual or non-material gains. And probably some of the reasons that we have this knowledge deficit is this reason. However, coming down to and trying my best not to talk too much. As a lawyer, as a politician, this is my genetic disposition to talk too much. I'll try to refrain from boring you a lot with my thoughts, but would like to simply mention one basic fact, that civilizations are created with the strength and power of ideas. It is the idea which is basically the light, the force, the impetus behind progress. As Iqbal said, "Jahan taza ki afkar taza se hai namood." Jahan taza ki afkar taza se hai namood. Ke sango khisht se hote nahi jahan paida. And this idea, this power, this afkar taza is the byproduct of research. It is the objective of research. It is the purpose of tahqiq, as outlined by Qari Saab earlier. Quran insists upon tafakkarun, wa tasharun, wa tafhamun, wa taqilun. Use your brain, use your mind, use your rationality. However, to what extent do we actually use it to benefit mankind? That's a question for us to answer. Issues are there, but this universe is incomplete. We need researchers. We need people who have the guts and the capability to explore this universe. Ye kainat abhi na mukammal hai shayad. कि दमादम आ रही है सदाए कुन फयकून. The process of creation is ongoing, and the process of discovery must also be ongoing. In order to meet the challenges of time, in order to meet new challenges, healthcare is your discipline. Of course, you are obliged to carry out researches and contribute in the development of mankind and to face these challenges. So far as the role of government is concerned, yes, it is our obligation as a government, as a regulator, to support and facilitate institutions like this. Private sector has come a long way in the process of, in terms of education, research, and similar activities. I believe there's no doubt in the fact that at the moment, all over the world, and especially in Pakistan, private sector education is contributing more in standard and quality to disciplines that are concerned with it. And medicine and health sciences are, of course, one of the most important areas where private sector is contributing a lot, both in terms of healthcare as well as education. Government of KP, as I'm representing it at the moment, yes, of course. Very recently, you might have heard that the government has announced to bring kidney transplant, liver transplant, bone marrow transplant, and cochlear implant. In the context of healthcare, we are giving it coverage now so that people who do not have the economic resources can benefit from it. Research is another area, but as I've heard and as told, yes, indeed, we must do something for granting the charter to Rahman Medical Institute and similar other institutions. We may have issues administrative, but inshallah look into it. And I promise that inshallah this problem will be resolved soon and expeditiously. Having said all this, once again, I thank you all for allowing me to address you and to vent out my feelings and express my thoughts. Thank you very much. Thank you.
Thank you so much, sir. As we approach the closing moments of this exceptional conference, it is now the perfect time to extend our deepest gratitude and appreciation to the visionary leaders and participants whose steadfast dedication and support have contributed to the resounding success of this event. For this, I kindly request that our esteemed chief guest, along with Professor Dr. Rahman Sahab, Chairman RMI, CEO Mr. Shafiqur Rahman Sahab, Professor Dr. Ghulam Rasool Sahab, Principal RCD, and Dr. Nasir Ahmed Sahab to please come forward. We are starting with the Young Investigator Award. Third position goes to Muhammad Hasnan. Second position goes to Mia Zahid Kaka Khel. First position goes to Muhammad Mujtaba. Now, Best Poster Award Undergraduate. Third position goes to Rahman College Nursing, Mehtab Jahan, Abdullah Shah, Yasmeen Afzal, and Mehreen Khan. Second position goes to KMC, Dr. Muhammad Abid, Meera Vas, Alishba Hamid, Omar Farooq. First position goes to KMU, Muhammad Nabi Malaika Ali. Now, Best Poster Award for Postgraduate. Third position goes to University of Peshawar, Imran M. Khanzi, Raza M. K. Shehwardi, Ahmed M.S. Best Poster Award Postgraduate. Third position goes to University of Peshawar, Imran M. Khanzi, Raza M. K. Shehwardi, and Ahmed M.S. Second position goes to Rifa International University, Nadia Bashir and Myra Asad. First position goes to Dr. Salman Khan, KTH Peshawar. We have another first position for Best Poster Postgraduate, Hina Shabir from KCD Peshawar. And Fatma Tariq from RCD. Now, rapid fire undergraduate. Third position goes to KMC Muhammad Shahir. Second position goes to Uzar Saljoki, PMC Peshawar. First position goes to KGMC Iraj Ikram. Next we have postgraduate verbal competition. Third position goes to Mubina Kadus, Sedu Group of Teaching Hospital, Swat. Second position goes to Saad Hayat, Khyber College of Dentistry, Peshawar. First position goes to Humna Zaidi, Dow University of Health Sciences, Karachi. Now we have best verbal presentation. Third position goes to Aga Khan University, Zara Masood. Second position goes to M. Raf Ilyas, Aga Khan University. First position goes to Swagartha Roy, Dhaka Medical College, Bangladesh. Next, we have postgraduate research showcase winner from Sadhu Group of Teaching Hospital, Muniba Kaddus. Now we have undergraduate research showcase winner. Third position goes to Sedhu Medical College, Lavangina. Second position goes to Sedhu Medical College, Manal. First position goes to Ahmed Ali Shah from Ahmedabad International Medical College. Now we have quiz competition winners. Third position goes to Khyber College of Dentistry, Nagina, Gulbakht, Mahnur, and Rehana. Second position goes to RMC Afaq Ahmed, Safura Zia, Muhammad Saqib, and Muhammad Zarghama. First position goes to KMC, Akib Muhammad, Abdul Mueed, Muhammad Umar, and Muhammad Sufyan. Let's give a round of applause to all our award winners. It is now time to recognize and celebrate excellence in research. To do the honors of announcing the Best Researchers Award, I would like to invite a distinguished academic, respected leader, and guiding force for many, Dean Professor Dr. Bakhtiyar Zahid Saab. Sir, please come to the stage.
Honorable Chief Guest, our very beloved and respected Professor Rahman Saab, CEO Saab, Professor Ghulam Rasool, and Dr. Nasir Saab, distinguished and esteemed guests and delegates, ladies and gentlemen, Assalamu alaikum. I know the word research has been repeated and repeated, and please allow me to repeat it once more. RMI has been fostering this culture of research, and in order to encourage and recognize our RMI healthcare faculty who have done excellence in research, we've been giving awards to those who provide highest research since last year. So this would be the second year in running where we'll be giving the Best Researcher Award, and what best occasion than the ICHR. A committee was formed which was humbly led by me, and then Professor Tariq Mufti Saab, Nasir Saab, Professor Abdul Wahid Saab, Professor Junaid Sarfaraz Saab, and we had some criteria set to make it very stringent because we had a lot of applications and only the top were selected for consideration for this award. And then the criteria was basically based on 4 factors, which included the number of publications, the impact factor, the citations, and also which quartile this publication went in. So the purpose was not only to have it on a piece of paper, as our worthy CEO noted, that it should have some impact on the normal day-to-day life of people. And therefore, based on this criteria, there were certain faculty who were selected for further second stage, and I'll just name them just to recognize and appreciate their efforts. And these included Dr. Wajiha Qayyum from RCD, Dr. Amanullah from RCHS, and Professor Tariq Tawfiq Khan, Taki Tawfiq Khan from RMI, Professor Rizwan Faisal from RMC, Dr. Aurangzeb from Nursing, Dr. Sohrab Khan from RMI, Maria Simab from RCHS, and Professor Dr. Ayaz Ayub from RMC. And believe me, it was a very tough competition, but we had that criteria set. So based on that criteria, I'm pleased to announce the winner of this year's Best Research Award, Dr. Taki Tawfiq Khan from RMC. Dr. Taki, as most of you probably know, is a renowned renal transplant surgeon and a urologist, and he has done wonders in his field. And with his busy schedule, he's been able to do some very high quality research, which is being recognized today. So a very round of applause, big round of applause for Professor Taki. Although this was meant to be only one award, and it is, but just to recognize the contributions of Dr. Rizwan Faisal, who was the runner-up last time, and again, by a very small margin, he's a runner-up this year as well. My congratulations to all those who participated in this contest, and the purpose of, from my little contribution with all these speeches, I would just like to say that we need to find local solutions for our local problems, and we have to do our work in that regard. Thank you.
Thank you so much, sir. Next, we are honored to present the award to Dr. Zuhair Yusuf Saab in recognition of his unwavering support in making ICHR-25 successful. Dr. Zuhair Yusuf Saab. Now we are honored to present award to Professor Abdul Ghafoor Sahab. Professor Abdul Ghafoor Sahab. Next, we'll present the honorary award recognizing individuals who have demonstrated outstanding commitment to Rahman Medical Institute. The first one goes to Professor Dr. Iftikhar Qayyum Saab, who is a renowned researcher and educator. He was the Director of Medical Research at RMC with degrees from King Edward's Medical College, the USA, and Quaid-e-Azam University. He founded Pakistan's first Department of Medical Research at RMC and the Center for Genomic Sciences, significantly advancing medical education and research. Professor Dr. Iftikhar Qayyum Saab. Now we want to acknowledge Mr. Muhammad Zakir Saab, who played a key role in improving healthcare at RMI through his leadership, innovation, and dedication. His efforts have made a meaningful and lasting impact on patient care and medical education. Mr. Muhammad Zakir Saab.
Now we would like our chief guest to acknowledge our leadership for their amazing mentorship. We extend our deepest appreciation to Professor Dr. Muhammad Rahman, Chairman of Rahman Medical Institute. Professor, Chairman of Rahman Medical Institute, Dr. Muhammad. Please give them a round of applause. Next, we honor a man whose dedication continues to uplift health research initiatives, Mr. Shafiqur Rahman, CEO, RMI. Moving forward, we acknowledge the invaluable contributions of our esteemed patron, Professor Dr. Ghulam Rasool, Principal, RCD.
And lastly, we are truly honored to invite the visionary behind ICHR-25, Dr. Nasir Ahmed, who is a distinguished physician scientist and a leader in clinical and translational research. He earned his PhD and prestigious European doctorate from the University of Verona, Italy, where he was recognized as the best graduate of the School of Life and Health Sciences. In 2024, he received the Best Researcher Award for his outstanding contributions to medical science with over 70 publications and an impact factor exceeding 100. He was authored 2 books published by Elsewhere and Springer Nature as the head of CTU and the founder of CCTM and the founder of CHR and the 3rd edition of ICHR-25. Ladies and gentlemen, it is with great pleasure that I invite Dr. Nasir Ahmed.
Next.
Thank you so much. Now, I would like to request Professor Dr. Rahman, Chairman RMI, CEO Mr. Shafiqur Rahman Saab, Dr. Ghulam Rasool, Principal RCD, and Dr. Nasir Ahmed to kindly present the awards to our esteemed chief guest. In recognition of outstanding services of cardiac surgery, Professor Rahman Saab, Professor Ghulam Rasool Saab, and also to the chief guest, Dr. Abdul Janan, Chief of Orakzai, a renowned medical scholar from KTH and reformer of Merj district, is pleased to come and present tribal traditional caps. Please give a big round of applause. Thank you so much, sir.
Bismillahirrahmanirrahim. It's really a great honor for me to be amongst such high-level esteemed delegation and gathering. It's a great honor for us. Today, it's a matter of great honor for us that we are having our esteemed Professor Muhammad Rahman Saab, Babai Cardiac Surgery of Pakistan. A huge clap for Professor Rahman. I know him since my student life. Rahman Saab is such a dedicated person that I have no words to encompass his services. His service is not only for Pakistan, but globally he is a renowned cardiac surgeon. So it's a great honor for KPK people that we are having such personalities, such assets in this province. It's a honor for Pakistan. And I belong to Merj district. I have nothing to present to him. But during war terrorism, whenever I have asked Professor Rahman Saab, he has very cordially, very humbly accommodated the poor war terrorist victim of the Merj district, for which I am really grateful to Professor Rahman Saab and his dedicated team. In the last, I should not forget the services of Professor Ghulam Rasool Saab, our esteemed professor of dentistry. He has rendered a lot of contribution in Khyber College on dentistry, and later on he has been here with us. He called me several times, Janan, don't miss this opportunity. So I really have the honor to come here to be before you people. In the last, and not the least, I must mention the services of Barrister Saab. This is my first interaction with Barrister, and he has rendered some services regarding law and order situation in district quorum, for which I have presented a cape to him, and I respect him, and I ask him to press hard on the provincial government to play positive roles in the Merj district, because the Merj district has suffered a lot. I can't see any more misery in the Merj district. So there should be no merit in the FATA. the FATA people should be accommodated in all university, in all colleges without merit, because they have very hardly served this country. FATA people have been suffered a lot. So I request all of you who are from the Merz district to contribute for the betterment of FATA. May Allah bless you in all of you. Pakistan Zindabad, Arimai Zindabad. Assalamu alaikum wa rahmatullahi.
Thank you, sir. With this, we officially bring the ICHR-25 ceremony to a close. We are deeply grateful to each one of you for being a part of ICHR-25 and making this special.
I think this will be incomplete if I don't announce ICHR-26. ICHR-26 will be tentatively held on 17, 18, and 19th of April next year.
Thank you, sir. We are deeply grateful to each one of you for being a part of ICHR-25 and making it so special. Your presence, participation, and enthusiasms are what made this event such a huge success. It's time for our lunch break. We'll resume shortly after the lunch and namaz break.
Thank you so much, sir. After the lunch and the namaz break, we will proceed with the CHR ceremony. Please, all the CHR participants, join us at 2 o'clock after your lunch and namaz break. Thank you, everyone.
seated in this row. That's to my left. And 15 to 19 on the right, please. 14 to 19 on the right, please. I'll repeat myself again. Batches 10 to 14 on my left and 14 to 19 on the right. Excuse me everyone, the CHR participants, batches 10 to 13, please proceed to sit on your seats on to this side, and batches 14 to 19 to my right, please. I'm sorry, 10 to 14 to my left and 15 to 19 to my right.
Dear audience, before we formally commence the event, I would like to invite our chief guest, Professor Dr. Asad Ali, CEO RMI, Mr. Shafiqur Rahman, Professor Dr. Ghulam Rasool, and Professor Dr. Nasir Ahmad to join us on the stage. Madam Sile is requested to please join us as well.
Madam Sila is requested to come on the stage.
Bismillah ar-Rahman ar-Rahim. Respected Chief Guest, Honorable CEO, Directors, Deans, distinguished faculty, dear participants and students, good afternoon. This is your host, Niza. Welcome to the CHR Certificate Distribution Ceremony, an integral part of ICHR-25. Today is the moment of celebration, reflection, and recognition. It's a day of honor to dedication, commitment, and academic achievement of all those who successfully completed the CHR program. A journey that not only enriched your knowledge, but also equipped you to contribute meaningfully to the field of health research. Allah beautifully reminds us in Surah Taha, verse 114, "My Lord, increase me in knowledge." This emphasizes the power, the need for knowledge and guidance, which is essential for growth, success, and meaningful contribution to society. Before we proceed further, let us begin in the name of Almighty Allah, the most gracious, the most merciful. To bless this gathering with the divine word of the Holy Quran, I would like to invite Professor Dr. Hafiz Abdul Ghafoor to come forward and recite few verses of the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم أمن هو قانت آناء الليل ساجدا وقائما ويحذر الآخرة ويرجو رحمته قل هل يستوي الذين يعلمون والذين لا يعلمون قل هل يستوي الذين يعلمون والذين لا يعلمون إنما يتذكر أولو الألباب صدق الله العظيم इरशाद बारी है तुम में से कौन ऐसा है जो रातों को अल्लाह के हुजूर में खड़ा रहता है और उसके हुजूर में सर बसुजूद रहता है और उससे आखिरत का डर रखता है और साथ ही अल्लाह से रहमत की उम्मीद रखता है। ए पैगम्बर सल्लल्लाहु अलैहि वसल्लम कह दीजिए, क्या जानने वाले और न जानने वाले यानी आलिम और जाहिल आपस में बराबर हो सकते हैं? ये निशानियां हैं उन लोगों के लिए जो अक्लमंद हैं। सुब्हान रब्बिक रब्बिल इज़्ज़ति अम्मा यसिफून व सलामुन अलल मुरसलीन वल्हम्दुलिल्लाहि रब्बिल आलमीन।
Jazakallah. Dear audience, Let us express our love and loyalty to our beloved homeland. I kindly request everyone to please rise for the national anthem. Thank you. Dear audience, the certificate in health research was initiated by Professor Dr. Ghulam Rasool, the patron of CHR, Professor Dr. Nasir Ahmad, Program Director, Dr. Muhammad Zubair Yusuf, Course Co-Coordinator, and Dr. Mohsin Shah, with a visionary goal to foster a culture of scientific inquiry, evidence-based practice, and ethical research in the healthcare. In CHR 2025, 14 badges have enrolled in the program. We are proud to share that 10 badges graduated in April 2025, and the remaining 4 will be graduating in June 2025. Throughout the course, the participants have engaged in comprehensive module encompassing research methodology, data analysis, research ethic, and publication strategies. The program carries 52 CME credit hours accredited by ACCME in collaboration with Aga Khan University, Karachi. It gives us immense pride to witness how each of you adopted the challenges and emerged with enhanced competence, confidence, and a deeper understanding of health research. It's my privilege to now invite a distinguished leader, a beacon of knowledge and guidance in the academic community, who has been at the forefront of educational excellence and has continuously inspiring both faculty and students alike. His dedication to nurturing the minds of future leaders is truly commendable. I kindly request Professor Dr. Ghulam Rasool, the patron of CHR and Principal Rahman College of Dentistry, to come forward and say a few words.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. In the written program, I was not supposed to talk something again. So I'm thankful to all of you for trusting us in this long course. And I have been there in your courses and taking the feedback of most of the participants. They were happy and you trusted because of our competent faculty, especially Dr. Nasir. He did a wonderful job. He is a true researcher in his heart. There is a pain for the research. He went to educate, he went to sensitize, he went to mobilize the community towards the research. And this is a blessing for Rahman Medical Institute that we have a legend like Dr. Nasir. He is always keen for the cause of research, and is in his leadership our journal of Rahman College of Dentistry got recognized from HEC and PMDC, and I, as you being trained in the research, and research project is one of the component of your course. So anyone, you are more than welcome to submit the article in JRCD, and we will honor you first because you are our scholar, you are the graduate of RMI in the research. Secondly, you are the one being trained in the research. There are so limited people in the research. We will need your support in the review of article and other technical support. We will time and again, we will request you, and I request that you should contribute to this journal. And you are the strength of RMI and our research department. If you want to continue your journey in research, please, my suggestion is start actively. And just after this conference, we are going to establish a mentorship program. And in that mentorship program, we are going to have expert visiting consultant in our research department, and whenever you need some support, technical support in article writing, in statistic, and in your results, study design, we will share a link for that. You can apply, you can book a slot, available slot in with our department, and we offer you both on-campus physical support and online support. Inshallah, we want to equip you further so that whatever you have learned, you produce that in the form of your article publication. And I hope you are the people in the whole conference, you understand the message of this conference. The theme of the conference is from discovery to impact. So I hope you will do and you will focus on the impactful research rather than fill in the blank and prevalence, incidence and frequency. Get out of these things. Please, we will provide you support, but some standard research is required. We will help you, inshallah, and we see you people, we will be more than happy that you come forward. And in the next conference, I expect that you should have a competition amongst the CHR group. You should come forward in each and every competition. You actively participate in the conference, and we own you because you are the RMI graduate in the research. Thank you.
Thank you, sir. Moving forward, I would like to invite a dedicated and knowledgeable individual to provide us with an insightful overview of the CHR. He has been an integral part of this program. We all are eager to hear about the journey, objective, and remarkable accomplishment of the program. I kindly request Professor Dr. Nasir Ahmed, Director CHR, to come forward and enlighten us with your valuable perspective.
Thank you so much, Niza. अस्सलाम वालेकुम जी, बहुत शुक्रिया आप सब लोगों का आज शाम को इतवार वाले दिन आने का. I am really thankful to Professor Asad Ali as the chief guest for this session. He traveled from Karachi to join us for this conference as well as for this session. And thankful to the management, CEO Shafiq Rahman Sahab, and patron ICHR and CHR, Professor Ghulam Rasul Sahab. And I would like to thank Madam Meera, who was the big applause for Madam Meera. ये बहुत मुश्किल काम था कि 14 बैजेस के कुछ 450 लोगों के साथ कोऑर्डिनेट करना, बैजेस का टाइम मैनेज करना, अटेंडेंस लगाना, हर चीज़ को मैनेज करना, इट वाज नॉट इजी टास्क। पिछले सालों में हमारे पास 4 और 5 बैजेस थे, डेट वाज रियली डिफ़िकल्ट टू मैनेज। और ये मिस मीरा की हिम्मत है कि आप सबको अप्रोप्रिएटली कम्युनिकेट किया, हर चीज़ के लिए टाइम ली। CHR की जर्नी हमारी नवंबर 22 में स्टार्ट हुई थी, जब हमने ये सिर्फ सोचा कि थोड़ा सा कॉन्सेप्ट कहाँ से लेके आए, रिसर्च का समझ नहीं है रिसर्च की कि रिसर्च होती क्या है। अनफॉर्चुनेटली हमारे यहाँ रिसर्च का जो विशियस साइकिल चल रहा है, कौन लोग रिसर्च करते हैं हमारे पास, जो ख़ास तौर पर मेडिकल के लोग हैं वो रिसर्च को थोड़ा बहुत हम समझते हैं कि थोड़ा समझते हैं, हम समझते हैं कि थोड़ा समझते हैं, लेकिन मसला वहाँ इतना ज़्यादा है कि वो सभी ही समझते हैं। क्लैपिंग तो कर लें, एक शेर बनाया है मैंने। असल में ये रिसर्च चूँकि बहुत पुरानी चीज़ है लेकिन हमारे यहाँ थोड़ी नई है, तो CPSP का जो एक सिस्टम है उनका भी कसूर नहीं है। वो चाहते हैं कि आहिस्ता आहिस्ता चीज़ें बेहतर हों, वो आहिस्ता आहिस्ता कुछ ज़्यादा ही आहिस्ता हो गया। वो कहते हैं जी कि आपका जो डिसर्टेशन और साइनॉप्सिस है वो पिछले 5 साल आपके इंस्टीट्यूट में वो रिसर्च ना हुई हो, 5.5 साल की खैर है, 6 साल की भी खैर है, आपके अस्पताल के साथ वाले अस्पताल की भी खैर है, आपके अस्पताल में 5 साल ना हुई हो। सो फिर हम क्या करते हैं कि हम 5.5 साल वाली पहले वाली रिसर्च को पकड़ लेते हैं और बहुत ही आसानी के साथ अपना साइनॉप्सिस बना लेते हैं, या कोई पुराना फेलो है तो उसका साइनॉप्सिस पकड़ लिया। मसला यहाँ पे ये है कि हम रिसर्च को आज तक समझ नहीं सके। सो रिसर्च हम करते क्यों हैं? मेरे एक टीचर हैं, अल्लाह उन्हें सेहत ज़िंदगी दे, वो कहते थे हम रिसर्च करते हैं, रिसर्च बराए रिसर्च करते हैं। रिसर्च के लिए नहीं करते, रिसर्च बराए रिसर्च करते हैं कि बस रिसर्च करनी है। हमारा पर्पज़ नहीं होता रिसर्च करना, हमारी मजबूरी होती है। मैं आज भी सुबह स्टूडेंट्स को कह रहा था, रिसर्च जो है ना वो इश्क और जुनून से कम नहीं है। अगर किसी के अंदर इश्क और जुनून ना हो ना, मोहब्बत ना हो, और ज़बरदस्ती की मोहब्बत लंबी नहीं चलती है। वो ज़बरदस्ती जब तक ज़बरदस्ती है तब तक ही रहती है और उसका आउटकम कोई मज़ेदार नहीं होता। रिसर्च एक पैशन का नाम है, रिसर्च एक शौक़ का नाम है। हमारे यहाँ हर बंदा जो है वो प्रोफेसर बनना चाहता है, हर बंदा जो है वो एक एकेडमिक पोजीशन लेना चाहता है, लेकिन हर बंदा रिसर्च नहीं करना चाहता। हमें आज तक इस बात की समझ नहीं आई कि अगर हम रिसर्च नहीं करेंगे तो ना काफिर होंगे, ना गुनहगार होंगे, और ना ही अपने प्रोफेशन से पीछे रह जाएंगे। ऐसी कोई बात भी नहीं है। हमें ये बात बहुत क्लियरली समझनी चाहिए कि अगर हमारा दिल नहीं है ना रिसर्च करने का, तो फिर हम रिसर्च ना करें। कोई भी मैंडेटरी नहीं है किसी भी डॉक्टर के लिए, नर्स के लिए, फिजियोथेरापिस्ट के लिए कि वो रिसर्च करे ही करे, नहीं तो वो सर्वाइव नहीं कर सकेगा। ऐसा बिल्कुल नहीं है। ये कॉन्सेप्ट हमारे यहाँ जो है इसको बेहतर करने की ज़रूरत है और हम सब मिलके इसको बेहतर करेंगे। बहुत सारे लोग होते हैं उनको शौक़ नहीं होता, और जिनको शौक़ नहीं है वो खुदा के लिए रिसर्च ना करें, वो रिसर्च का कबाड़ा करते हैं। सो रिसर्च करने के लिए आपके अंदर सबसे पहली चीज़ क्या होनी चाहिए जी? इश्क। तो मैं अक्सर पूछता हूँ तो सबसे पहला स्टेप रिसर्च में क्या है? रिसर्च में सबसे पहला स्टेप क्या है जी? एरिया ऑफ इंटरेस्ट। आज तक हमें ये समझना ज़रूरी है कि हमें प्रॉब्लम आइडेंटिफाई करने से पहले, रिसर्च क्वेश्चन डेवलप करने से पहले, रिसर्च क्वेश्चन को फार्मूलेट करने से पहले हमें इश्क करना होगा। इससे पहले इससे एक जुनून की हद तक मोहब्बत करनी होगी, और वो मोहब्बत जब हो जाएगी तो फिर उससे बाहर के हमने मसले नहीं सोचने, फिर वहाँ पे हमें मसले नज़र आएंगे। अगर बाहर की मसला नज़र आ भी गया तो वो हमसे नज़रअंदाज हो जाना चाहिए, क्योंकि रिसर्च एक फोकस्ड चीज़ का नाम है, एक टनल विजन का नाम है। हमने जब ज़्यादा एक्सप्लोर करने हैं, हीरे और जवाहरात ढूंढने के लिए हमें बहुत नीचे जाना होगा, और ऊपर हमें कुछ भी अच्छी चीज़ नहीं मिलती है। इसलिए हमें दूर देखने के लिए भी छोटी आँख करनी पड़ती है ना, आँख बंद करनी पड़ती है। किसे क्या कहते हैं, कौन सी ऑप्थेल्मोलॉजी में क्या टर्मिनोलॉजी होती है? चलें ठीक है, बहरहाल दूर देखना हो तो आंख बंद ही करनी पड़ती है। सो हम सब ये बात समझ गए हैं कि रिसर्च की डेफिनेशन तो आज सुना दें, बात ख़त्म करते हैं। रिसर्च इज़ समथिंग दैट इज़, सब पढ़ लेना, सब कुछ सुनाया हुआ याद है सबको। रिसर्च इज़ समथिंग दैट इज़ नॉट नोन येट एनीवेयर इन दी वर्ल्ड। Research is something that is not known yet anywhere in the world, in any language of the world, in any corner of the world. अगर दुनिया के अंदर किसी भी जगह कोई चीज़ known है तो दोबारा उसको करना रिसर्च नहीं कहलाता. आप सब लोगों को वो शराइत पढ़ाई हैं कि जिस शराइत पे आप दोबारा कर सकते हैं उसकी कंडीशंस हैं. उसके लिए दो चीज़ें आपको साबित करनी होंगी. जो डिजीज़, जो ड्रग, जो प्रोसीजर, जो इंटरवेंशन आप चाहते हैं कि दूसरी जगह करना है, पहले तो ये लिंक इस्टेब्लिश करना होगा कि उसका किसी भी इन्वायरमेंटल, वेदर, टेम्परेचर, जेनेटिक्स, एथनिसिटी के साथ कोई लिंक है. और दूसरा क्या शर्त है कि जहाँ पे आप कर रहे हैं और जहाँ पहले हुई थी वहाँ का एथनिसिटी, वहाँ का टेम्परेचर वो डिफरेंट है. सिर्फ इस सूरत में कर सकते हैं. इसके अलावा कभी भी दुनिया की कहीं की हुई रिसर्च को दोबारा नहीं कर सकते. सो ए और बी सर्कल सबको याद है. वी हैव टू गो आउटसाइड एग्जिस्टिंग नॉलेज. अगर एग्जिस्टिंग नॉलेज के अंदर रह के बहुत सारी रिसर्च कर लें, हज़ारों पेपर लिख लें, हम रिसर्च नहीं करेंगे. थैंक यू सो मच. आप लोगों ने बहुत मेरी बातें सबने पहले सुनी हुई हैं, इसलिए मज़ीद बातें नहीं करते. इसके साथ ही थैंक यू सो मच.
Thank you, sir. Dear audience, we are honored to have a visionary leader who have made significant contribution to the field of health and education. He has been at the helm of transforming health services and fostering excellence in the medical field. It is requested to Mr. Shafiqur Rahman, the esteemed CEO of RMI, to share his thoughts.
Bismillah ar-Rahman ar-Rahim, and a very good afternoon. I'm sure you've all been exhausted over the last 3 days and can't wait to get out of here, but I've been asked to say a few words, so I will. First and foremost, a warm congratulations not just to the people organizing this program, but all the worthy participants as well. As the story of RMI goes, and we keep repeating this story through everything that we do, the question that we ask ourselves is not the why, but why not? And I think it is with that spirit that this program was started off, questioning why couldn't such capacity building initiatives happen in this city and in this province where it is so much needed. As Nasir Saab rightly pointed out, whenever you want to bring about a change, you need to ensure you have an adequate capacity building activity done first. It is just like if you are going out to fight a war, you just don't decide one fine morning, let's go and have a war. You spend a lot of time preparing for it, preparing the capacity and building that capacity. And this is not a shortcut, it is a struggle for the long term. And this is the long-term struggle that we intend to continue to ensure there is a critical mass of knowledge that is created in this region, not just in this one institution, but overall in this province. And those individuals, many of you, are then expected to bring about this change, to propagate this message, to expand this, and to then deliver on the objectives that were set out earlier. It is very easy to sit in your comfort zone and not really expand your knowledge or go into this direction, which is why I would like to pay tribute to everyone who stepped up and decided to enroll in this program, to expand this knowledge and to arm themselves with the skills required to move from clinical care to inquiry and addressing the critical questions that exist out there. As was said earlier, I will not try to add much more, but I'd just like to emphasize the fact that what's important is for us to address our own challenges, apply the knowledge, and in Pakistan, we don't have a dearth of challenges. Unfortunate in one sense, but there's plenty of challenges that exist in the healthcare sphere. So do identify the challenges that affect our people in our region and see how you could apply your knowledge to address those gaps and to solve the problems that exist. The journey of learning does not stop. This is but one step, and I hope we will facilitate this journey going forward by introducing many other programs to continue to update yourselves. Knowledge is being created as we speak. It is created at an exponential pace, and it is absolutely essential for us to keep abreast of all the changes that are occurring worldwide and to apply that knowledge to our own problems. So warmest congratulations to all the participants who've enrolled in the program, to all the organizers who've put this together, all the collaborating partners from Khan University and any other team members who've contributed to this. We're really grateful from RMI for all your support, and we look forward to continuing this journey and producing many other programs with even a wider participation, inshallah. Thank you and all the best.
Thank you, sir. Now, I would like to invite our Honorable Chief Guest, Professor Dr. Asad Ali, the Chair and Professor of Department of Community Health Sciences at Aga Khan University, Karachi, is a distinguished leader in public health, epidemiology, and health research with extensive experience in community health, disease prevention, and healthcare policy. Sir, it is requested to you to kindly say a few words.
Bismillahirrahmanirrahim. Thank you very much. It's a great honor to be here. I want to thank the organizers again for inviting me. I am very thrilled for multiple reasons, and I think this is the time to celebrate. But I think there are few things that I think are pretty remarkable to me as I learn more about this. I think the first thing to celebrate is the commitment of the institution towards capacity building. I think the whole institute, the Rahman Medical Institute, and the whole organization, we really do need institutions in Pakistan. You know, they say that the challenge of Pakistan is lack of institutions. You know, earlier we used to have very high quality institutions. PIA was the institution which actually kind of, you know, really played a critical role in the development of Emirates. The flights EK is because, you know, the first flight was from Emirates to Karachi. So that's how the name EK came, which still is there. So we used to have very strong institutions, and then those institutions kind of faltered. But now, you know, creation of these strong institutions is a very big service, and I'm really thrilled to see the commitment that the institution has towards capacity building and so many people in here. Second thing I'm very happy to celebrate is the team. The team that has created this course and many courses like this, the team that has organized this whole conference. So, you know, you need dedicated people, and I'm just thrilled to see so many, this place has so many of these dedicated people, right from hosting the conference to, you know, the hospitality and everything. I think that is something to really celebrate. The third thing that I am most excited about is the people, is the students and the participants of the course. I mean, the spark that I see in the eyes of the participants, I think that what we have here are future leaders of Pakistan. And I think that's you. You guys are going to be the one who are going to, you are being enabled by the institution, by the organizers, but, you know, it will be you. And, you know, this area has produced many, many leaders. I mean, we have Rahman Saab himself and also many other big leaders who really have transformed the whole country, the whole region. And I really hope that you will also kind of continue in that legacy and really be a powerful. And, you know, the biggest determinant of whether you will do great things in life or whether you will not do good things, great things in life, is what you believe. Yeah, if you believe in your heart that I will make a difference, I will change the society, I will change the world, then you will. And if you don't believe in yourself, if you think, KGO, I don't have this, I don't have that, then you will not. Today, those who are the participants of this course and who are, you know, the students in here, you have some excellent resources at your disposal. Plus, the world has become so small with the internet, with the artificial intelligence, that really you have access to much of the courses, much of the didactics that anybody in the US or in UK would have. You know, many of these courses are available online for free. This is a luxury that was not available to the previous generations. So I think we have the agency. I clearly can tell you have the talent and the spirit to learn. And I think, inshallah, with the belief that you will have, that you will be the one who will make remarkable things in the world, I really think that, great things will come out of this institution and of you. So all the best and my thanks for all the hard work that has been put in here. Thank you.
Thank you, sir. Before we move ahead, I would like to take a moment to acknowledge the tireless effort of the dedicated CHR team, Professor Dr. Ghulam Rasool, the patron, Professor Dr. Nasir Ahmad, Program Director, Dr. Zohair, Dr. Zille Huma, Dr. Najma Basir, Dr. Mohsen Shah, Dr. Iqbal Wahid, Dr. Wakar Ali, Dr. Najiha Iqbal, Ms. Meera Tanveer, Ms. Romaisa Kiran, Mr. Falak Nas for IT support, Library Office Aide Mr. Haider, Ms. Saira Sayyid, Mr. Abdul Basid, Mr. Hamid Habib, FNSD Mr. Kaleem and team, Organizing Committee, Faculty Mentors, Coordinator, Administrative Staff, and our invaluable colleagues from KMU, AKU, Northwest General Hospital, and of course, RMI.
सबसे ज़्यादा शुक्रिया मेरी वाइफ का कि पिछले 2 सालों से हर वीकेंड में आप लोगों के साथ होता हूँ, तो उनके लिए एक क्लैपिंग होनी चाहिए, ठीक है ना? मेरी वरना घर में जगह नहीं है, ठीक है? तो आप सबका शुक्रिया और मेरी वाइफ का बहुत शुक्रिया, थैंक यू।
I would like to request Ms. Seemab and Mr. Mazil Mubashir from IFMSA to come up on stage and say a few words.
Hello everyone, I hope everyone is doing good. So let me introduce myself first. This is Seemab Mahmood. I'm the president of International Federation of Medical Students Association, Pakistan chapter. The biggest medical student community has been working since 2001. First of all, I would like to say a humble thanks to Dr. Nasir Ahmed for involving us as a gesture of meaningful student involvement. Though they have very informative talks and exciting, exceptional vision about research, I just want to add or quote the words of Mary Lasker. If you don't want to invest in research, try disease. So we do have 2 other options. With that vision, IFMSA Pakistan truly believes in the empowerment of students, not only in terms of capacity building, but in providing the opportunities. And for that vision, with that vision, we are truly humbled that the students have been actively involved in this conference, international conference, and we are delighted to have our delegations of 8 representing from the different provinces of Pakistan to be involved actively here. So thank you so much with that vision. We are truly humbled. And we are looking forward to see how the students can engage directly with the vision, the mentorship, the opportunities we have, and how we can be the drivers of change in the upcoming world. So thank you again.
I would like to invite Professor Dr. Nasir Ahmed to please come forward and receive his token of appreciation from IFMSA.
Thank you. Now it is requested to Mrs. Sileh Sarak Rahman to join us on the stage to appreciate the students' team of media volunteers of RMI Education.
I need my phone, sorry, I have the names. Assalamu alaikum, everyone. So I take this opportunity to thank the students who were involved in marketing team. These students are not professionals. They are coming from RMI's different colleges. And since this is the last event that we have for ICHR, I thought we have to give them credit for doing an amazing job. Whatever you see on RMI social media is as a result of their efforts and their hard work. So please clap for them. Thank you. I'd like to call on Rana, Zainab, Shoema, Faiza, Ariba, Omaima, Ayush, and Ramin. I would like to introduce you to the RMI team of media students. These are the students behind everything that have been captured over the last 3 days. Thank you so much. Thank you, ladies, and thank you, Ayush. Thank you.
Thank you so much, ma'am. Dear audience, now at the moment we've all been waiting for, the distribution of certificates. I request Professor Dr. Asad Ali to kindly come forward and present the certificates to the participants. An important note to the participants: the certificates currently being distributed are temporary. Official personalized certificates will be issued shortly through the RCD lobby, categorized by name. As I call out your name, please come forward to receive your certificates. Malaika Khan, Momin Sayyid, Mahin Khan, I would request the CEO, Dr. Shafiq, and Professor Dr. Ghulam Rasool to join Professor Asad Ali on stage, please. Faisal Hayat, Ulfat Sultana, Muhammad Wajahat Jan, Musawwir Hussain, Rumesa Kiran, Meera Tanveer, Noman Wazir, Rahatullah, Abdul Wahab, Anisa Khan, Muhammad Abbas, Zaid Iqbal, Ziyauddin, Muhammad Salman, Shiraz Khan, Muhammad Sadullah Khan, आफ्ताब अली, ईसा खान, माज खान, रज़ा मोहम्मद, इलियास खान, वलीद मलिक, आमिर अब्बास, मोहम्मद हासिम, हिशाम अरशद, नदीम अहमद, मोहम्मद आतिफ आलम, फ़हद अहमद, अब्दुल सुबहान, शहाना रहमान, फैज़ान शाह रुहानी, मुनाइल रुहानी, सैयदा नूर सबा, अब्दुल सलाम, मोहम्मद फुरकान, Mishkatullah Khan. Now moving on to batch number 11. Salman Khan, Maimuna Sardar, Bakhtawar Kakad, Mansoor Ahmed, Imran Khan, Arsalan Shah Roghani, Hanifullah, Zubair Ahmed, Sara Kulsoom, Salman Shah, Kamran, Umar Tariq, Waqar Ali, Wajid Ali, Fahimullah. Harun Khan, Uzairul Islam, Sher Rahman, Shahzad Faiz, Bibi Khatija, Fariha Afridi, Mujtaba Zahid, Muhammad Shah Fahad, Muhammad Musa, Muhammad Nayab Ali, Muhammad Zubair, Hamid Salman, Faik Imdad, Aisha Zarpash, Muhammad Waqar.
Now, batch 12, Amina, Murad Ali, Muhammad Fayaz, Qazi Yusuf Ali, Asad Khan, Asif Nawaz Afridi, Danish Marwat, Asma Anwar, Danish Nabi, Intizamul Haq, Wali Rahman, Hilal Sultan Farooq, Rafaqat Hussain, Muhammad Siddiq Khan, Muhammad Usman Khan Gigyani, Halima Sadia, Nayab Gul, Muhammad Umar Naeem, Muhammad Kamran, Yunus Khan, Ijazullah, Fazal Amin, Muhammad Saeed Ahmed, Sayyid Muhammad Najib, Saiqa, Arifullah Khan, Muhammad Umar Rafiq, Asneed Alam, Sanan Khan, Shakirullah, Abdul Kabir, Ahmadullah Zaryab, Imdadullah, Muhammad Adil, Rimsha Afridi, Muhammad Noman,
Now moving on to batch 13, Mir Abid Jan, Hifzur Rahman, Asna Tahir, Ali Raza, Abu Zar, Habiba Inayat, Amjad Iqbal, Faizan Banaras, Rehan Ullah, Yasir Maluk, Anam Riaz, Asia, Zishan Abdul Nasir, Ataullah Safi, Muhammad Tufail, Inayatullah, Hamza Khan, Irfan Khan, Ayman Liaquat, Nazish Hassan Wazir, Ezazuddin, Waqar Khan, Abidullah Shah, Sadia Muhammad, Allah Yar Khan, Ahmad Arif, Muhammad Asfar Zafar, Wajiha Arif, Haider Ali, Himayatullah.
Batch 14, Amir Ahmed, Arisha Riaz, Asad Khalil, Asif Anwar, Asmat Khan, Ataullah Haq, Dawood Tahir, Afra Siab, Fasiur Rahman. Fatma Noor, Fayaz Ahmed, Hamad Ahmed Saif, Hamza Usman, Ihtisam Yusuf, Muhammad Nabil Hayat, Muhammad Khuzaifa, Muhammad Tamhid, Nawal Maqbool, Rabel Irfan, Ihtisamul Haq, Ruwaid Ahmed, Saad Ali Shah, Sayyid Yasir Jamal, Shahzad Rahi, Uzma Waheed, Yasir Khan, Zahra Ahmed, Zarak Khan, Zoha Asim, Muhammad Noman Arshad, Muhammad Salim Khan, Muhammad Yunus Ali.
Now batch 15, Amirullah, Asghar Ali, Atif Bashir, Ataullah Wadood, Ataullah, Azhar Birlas, Felicia Gul, Fayazullah, Hira Shamim, Imad Ahmed, Ishrat Fatma, Israr Khan, Junaid Bahadur, Khizr Zaman. It is requested for Professor Mumtaz Ahmed to join us on the stage, please. Muhammad Ali Noman. Mohammad Bilawal Khan, Mohammad Yahya Khan, Mukanza Jahanzeb, Naumanul Mulk, Palwasha Sardar. Peer Tufail Ahmed, Sajjadur Rahman,
Durrani, Naveed Zaman.
Now on to batch 17, Adnan Khan, Ahmad Amin, Alina Khan, Asma Khan, Aisha Johar, Aisha Siddiqa, Muhammad Basit Alam, Dr. Aisha, Hasnain Ahmed, Irfanullah, Javeria Anjum, Kalimullah, Kamal Ahmed, Laila Khan, Muhammad Hunain, Nasir Ali Shah, Saeed Khan, Sana Gul, Sayyid Muhammad Zuhaib, Shehzad Rahim, Muhammad Suhaib, Sumbul Rani, Sayyid Sadan Shah, Tariqullah, Umair Imran, Wajiha Gul Pirzada, Zahid Rahman, Zuhaib Ahmed, Faryal Tariq.
Batch 18, Adil Khan, Asadullah, Bakht Babar, Fasiullah, Kulrukh Begum, Hidayatullah, Khizr Hamza, Khushbakht Zainab, Kifayat Ali, Laila Shaukat, Madina Khan, Misbahur Rahman, Muhammad Abdur Rahman, Muhammad Faizan, Naveed Liaqat Ali, Palwasha Ijaz, Saddam Khan, Sajid Razak, Shandana Khan, Sogat Tariq, Taimur Khan, Tayyib Afreen, Waqar Ahmed, Waqas Ahmed, Waqas Khan, Warda Javed, Zarak Khan, Ziaullah Khan, Idris Ismail.
Batch 19, Umme Habiba, Shireen Anwar, Sufyan Khalil, Rabia Vilayat, Safa Rashid, Tahir Arif, Bilawal Habib, Yasir Rashid, Gulale, Anam Zaman, Muneeb Khan, Fayazur Rahman, Muhammad Hassan Khan, Sana Yusuf, Umad Israr, Umayma Khurush, Safirullah, Jawad Ahmed, Waqar Kabir, Rashid Khan, Khurram Shehzad, Mehsan Bibi, Ramin Siddiqui, Roman Khan, Hasnain, Amir Iqbal, Muiz Inam Khan, Imran Shad, Ahmed bin Khalid, Saad Ijaz, Wajid Ali, Kashif Rahim, Yasinul Haq, Malak Mustaqim Khan, Sanaullah, M. Bilaluddin. Now I request Professor Dr. Asad Ali, Professor Dr. Nasir Ahmed, CEO Shafiqur Rahman, Professor Dr. Ghulam Rasool to present the shields to our CME department. Now I call Mr. Farhan up on the stage to receive his shield. Is he here? Bring it. Mr. Farhan nahi hai? Mr. Farhan nahi hai? बोलूं हाँ लाओ सारी शीट्स लाओ चीफ गेस्ट का भी लाओ As Dr. Natasha is not able to join us today, I'd like for Sir Professor Asad Ali to receive her shield. Now I call our Honorable Chief Guest, Professor Dr. Asad Ali, to receive his shield. Now I call Dr. Janan to receive his shield. Please join us.
As we conclude this edition of the International Conference on Health Research, ICHR, it is our pleasure to extend sincere thanks to each one of you for your valuable contributions. And we look forward to welcoming you again at the future editions of the ICHR. Thank you, and we wish you all the best in your endeavors.